नहीं नहीं, वो मेरा जो प्रिस्क्रिप्शन है वो भेज दे उनको। लास्ट टाइम किसने, विपुल ने कराया था, उसको पूछ ले।
एरोप्लेन मोड पर मुकी तो बता।
विपुल ने कैसे कराया था लास्ट टाइम, पूछ लेना।
Not aeroplane mode. हाँ,
Put it
yeah.
on
उसके बाद
aeroplane
उसका
mode.
वो
Mode.
है ना, विपुल ने लास्ट टाइम करवाया था वो पेशेंट का। विपुल था या कौन था, उससे पूछ ले, ठीक है ना। मेरे को फोन मत करना, मैं एक वेबिनार में।
अब फोन बैकग्राउंड में बंद करना, ये रिकॉर्ड हो गया हाँ ऑलरेडी प्रथमेश भाई।
प्रथमेश एरोप्लेन मोड पे रख दे, बेटर।
संजय केम છો? गुड मॉर्निंग
ऑल वेल निश्चित भाई।
नवीन भाई। हाँ ब्रिजेश,
सर मजामा।
जय 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 ब्रिजेश, जय 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 गुरुदेव।
जय गुरुदेव।
जय गुरुदेव, जय गुरुदेव। निशित भाई।
हाँ अरे
नमस्कार नमस्कार।
तुम ये एक इसका एक ले लेना बराबर पिक्चर, जिंदगी में ऐसा मिलेगा नहीं फिर से बॉस।
निश्चित भाई તમે हेडफोन भराई दो।
न्यू गुजरात स्टाइल।
निश्चित भाई यू स्टार्ट विद द हेडफोन, दैट
Headphone
मोबाइल
भराई दे।
एक्सेसरी
ओके
प्लीज
सार
प्लीज प्लीज।
मोबाइल वालों भी चाल से।
ना ना
ओके आई एम स्टार्टिंग। So welcome to all and thanks to all the faculty on behalf of Gujarat Orthopedic Association for accepting the invitation of Gujarat Orthopedic Association for sharing, contributing and learning together. For delegates, the page you have opened is 48 webinar and here is the link for previous webinar recording. Just click this link and you will get that webinar here, all the webinars. Today, our subject is the case and technique based shoulder problems and solution, focusing on the general orthopedic surgeon day-to-day problems, particularly the differential diagnosis of the shoulder pain when the patient comes to the clinic. What will be the clinical examination, radio, sono, MRI correlation, what can be the injection technique you can learn from the masters, and a manipulation of shoulder and a mini open cuff repair, and some of the important points, tips and tricks from all the masters. These are all masters of the shoulder. So we are thankful to all the masters and we are thankful to Dr. Prathmesh Jain for coordinating all the masters together, right? So as you go down and you see here the arrow, red arrow, click this red arrow. Here is your live webinar. You can see here live. Once you see and you have any question, just type your question here and just click the button send. We have limited 160 characters only to have a crisp questions only here, right sir? And those who are having a different device, there may be a button to ask. Just click the ask button and your question window will open there. And those who are seeing with a very small device or they do not have a space to write, then they can record their audio or a video in a WhatsApp application itself and just click WhatsApp to Dr. Navin. It will come to me and I will pass on to the moderator and faculty. Okay, in between also you can ask the questions. Let me introduce in a shortly, probably the detailed introduction will be given by Dr. Prathmesh. Dr. Ashish Babulkar, everybody knows him about the shoulder. He is a great teacher, so we'll learn many tips and tricks from him. Dr. Nishit Shah is our senior arthroscopic surgeon from Ahmedabad. Dr. Sanjay Trivedi, he does a lot of work on shoulder. And Dr. Kalpesh Trivedi, also he does a lot of work on the shoulder. These are all well-known arthroscopic and shoulder surgeons. Dr. Pritesh Shah is also a young arthroscopic surgeon and he is also very, very much experienced. We have Dr. Drashti Patel as a musculoskeletal radiologist. So we'll have a correlation with the X-ray, sono and MRI. Dr. Prathmesh Jain, he is the real moderator of this whole session. Dr. Sanjay Chaturvedi from Agra will join shortly. He also does the arthroscopy there. Dr. Manoj Chaudhary from the Bhagalpur, Bihar is the president of Bihar Orthopedic Association. He will be asking questions related to general orthopedic surgeon. Where are the problems? And he will be representing in a way audience within this faculty. Same way Dr. Akhilesh Yadav, He's from the Durg and he's the honorary secretary of Central Zone of IOA. And myself will be just coordinating between you. So let us start. Dr. Prathamesh, take over the screen, start sharing. My screen will go automatically. I allowed the multiple screen sharing. Okay? Start sharing, please. Fantastic.
Good morning, everybody. So we'll just be starting with the first case, which is pertaining to a general orthopedic surgeon. A 40-year-old female presents in the OPD with a severe excruciating pain in the shoulder for 5 days. She has inability to sleep. The pain was not relieved with painkillers, ibuprofen, and she didn't allow me to touch her shoulder in the examination. She is very, very painful. Now the question to all the delegates is, what will be the next step that we are going to take? We'll give a stronger pain medication and start physiotherapy. We'll do an X-ray, we do an ultrasound, or we'll do an MRI scan. Navin sir, maybe Dr. Akhilesh can answer this.
Yes.
Just for primary investigation, X-rays and all these things, we go for primary investigation first.
So definitely we'll go ahead and we'll get an X-ray of this particular patient done. And this was the picture we got in the X-ray.
Yes, we can go for MRI and ultrasound also after that.
Yes, sir. So we got an ultrasound and an MRI, which shows this kind of a picture. So now questions to all the faculty. What will be your next step? Physiotherapy, NSAIDs, USG guided needling, arthroscopic excision, extracorporeal shortwave therapy, and steroid injection. I'll start with Dr. Babulkar. What sir has to suggest us
Right.
in tackling this condition?
Prathamesh, in our country, this is not an uncommon condition. In the West, this is not very common. And there are two versions to this. If the acute presentation is extremely painful, intolerant, and it's like an abscess pain, and they will need intervention. Same patient comes after 2-3 months, is going to be quite quiet. They may have weakness, but the pain has gone. And then I don't intervene in those cases. You just put them on physiotherapy. Your patient looks like he's in acute agony. So I practice a OPD based ultrasound guided needling procedure. This is done in sync with a musculoskeletal radiologist. You need 4 hands to do this. And if it's amorphous, if it's liquid, you can actually aspirate most of it. It is inconceivable you can remove all of the calcification, but you can remove it. If it is hard and gritty, then you will need to pepper pot it and wash it out. And the pain relief is quite dramatic. Whether to add steroid or not is controversial because steroid itself can cause calcification. So if it is in severe agony, I add a steroid injection along with that, but I don't do that always. And I must start physio immediately the next day. I think this is the most optimal way to treat them.
Dr. Kalpesh, would you like to give injection in this particular case?
Yes, particularly when the pain...
Can you put back that the same X-ray or MR picture so that...
Yeah.
Yeah.
So Prathamesh, the sudden onset pain in a relatively younger individual without any history of trauma should give in your back of mind calcific tendinitis is the diagnosis. And when we see such type of picture along with the barbetage or needling, the tendon is usually very much inflamed. So putting a steroid in the subacromial bursa can definitely reduce the pain and inflammation and ultimately relieve the pain. Yeah.
So would you take the help of ultrasound, or you'll do it blind?
100% absolutely ultrasound guided. Because the inadvertent injection within the tendon can cause weakening of the tendon, and subsequent rupture it will lead to rupture of the tendon subsequently.
Anybody in the faculty has experience of ESWT, especially Pritesh bhai? Extracorporeal shortwave?
There is one doctor in our city who is doing a lot of ESWL.
Dr. Shrenik Shah.
Yeah, he has got good results. But my personal experience with this thing, many times it presents with a tear. And if we try to repair this tear, then you are gone. it keeps on, you remove the calcium and it keeps on removing more and more tendon, and you end up with a non-repairable tear. So in this type of cases, I would avoid operating for any kind of repair or directly going. So better is needling or ESWL, something like that.
Dr. Ashish sir wants to say something to add on that.
Can I?
Yeah, sir.
So, 15 years back, when we did not have the facility to do
Ultrasound.
ultrasound guided, we were unaware of what this was. Um, we used to do ESWT. Now, ESWT for renal stones is different. It is deep seated. It is still painful. For a superficial joint, it is incredibly painful, even if you apply the lowest readings. So we did it for 3 patients, and the third patient actually ran away. And we realized that this is not the way to do it. We followed all international protocols, and all the double-blind randomized studies show that ESWT does not work as well as other modalities. I think now, with evidence, there are only two ways to address this. One is babotage, ultrasound guided, and the other is arthroscopic excision,
Yes,
which might be an
absolutely.
overkill. But any calcification that is more than 4 centimeters, now in both planes, this present calcification is almost 4 centimeters long, medial lateral. But if it's also in the AP plane, then needling will cause syncope. Patient will not tolerate it. It cannot be done OPD basis. Then we resort to an arthroscopic removal, which is rare. It's like 1 in 50 patients. So 49 patients would undergo needling.
Okay, Dr. Sanjay Trivedi wants to add something, probably.
I think in acute condition, extracorporeal shockwave therapy doesn't really work because it requires several sets, and sometimes accumulated pain is much more than the pain of this calcific tendinitis. Injection or needling babotage is the best therapy, and I always add triamcinolone along with it to take care of acute inflammation. And with the experience, you can always put the needle in the subacromial space. So the general orthopedic surgeons who are not having access to ultrasound right there and there, they can always use a subacromial injection technique without even ultrasound, without too much of an apprehension. That is my suggestion.
So, so
So
we did.
wide bore needle and steroid injection will be enough according to you, Sanjay?
Most certainly. Not even wide bore needle.
No, wide bore needle, but how will you remove the
You don't
uh,
need to remove
active?
it, Nisit sir. You can, because you don't know whether it is amorphous or it is calcified. But if you disturb it by several, attempts to reach in that direction, sometimes what happens, you come to know that, your 18 gauge needle will not let you push the, sensor cane filled triamcinolone. At that point, you understand, you remove it. You always use local infiltration on the skin before you start this procedure, a wide area or proposed area for where you want to put your needle, and then repeated multiple direction changing. You can always take care of it. You don't need to remove this calcium during the injection. That is what I have understood with this.
But
And
Dr.
such a
post
Yeah,
large
X-ray, you can see some calcium, and eventually it disappears.
Dr. Kalpesh wants to add something. Yeah,
Yeah,
please.
many times we have seen that in patient presenting with similar symptoms, we find calcific tendinitis involving the subscapularis tendon also. So when you take AP X-ray in subscapularis tendon calcific tendinitis, almost all the times you can't see anything. So I would recommend to take cross-table lateral, transaxillary lateral view, or you can take help of CT scan or MRI to diagnose this condition.
So it is always to be MRI to be done, according to you.
Not always, but when you suspect calcific tendinitis, severe
No, no, no.
pain,
What the message should go to the general orthopedic surgeon.
so
That should be clear.
so when in AP X-ray nothing conclusive is there, you can take help of either transaxillary X-ray or MRI.
Okay.
Yeah.
Dr. Ashish Bhai wants to say something. Yeah,
Actually, I'll withdraw my remarks. I'll wait for my talk to come in and then we'll elaborate.
okay, okay, fine, fine. Okay, fine. Dr. Pritesh bhai,
Yes.
okay.
Yeah, I would always go for MRI before doing any kind of an invasive procedure like needling also, because legal issue also. So even if it turns out to be a small tear after needling on MRI, patient can always blame you. So better to have MRI on hand before.
For documentation, you require it.
Yeah.
Okay. Nishit bhai, do you want to add? Otherwise, we go further.
No, it's okay.
Okay.
So we just go ahead and did an arthroscopic procedure, and we could achieve a good removal of the calcium fragments. Now, my question to the faculties is complete removal of the calcium deposits required during the arthroscopic procedure, or we can just take out what we want? Ashish, sir.
So it's a very difficult question you've asked. I always counsel my patient that we are going to attempt to remove everything. Now, the $1,000,000 question is, if it is subacromial, I will endeavor to remove all of the calcification. And that's an easy peasy job because you can see it there in front of. Sometimes it's part subacromial, part intratendinous. And then when I have to disturb the tendon, I would prefer to disturb it only with a needle so as to not cause a macroscopic tear. Microscopic tears will heal very nicely. But if it's a big whopping one, or sometimes it is entirely intratendinous, and that is the dilemma, in which case I have to split the tendon open, use the shaver, create a tear, and then repair it completely. Now, if that tear is less than 50% of depth, and you need a little bit of experience to decide, then I will leave it alone, because my biggest advantage is I can start the exercise within 5 days. But if I have to repair it, then I have to wait for 6 weeks, let it heal, and that patient is miserable. So functionally, that patient is not happy, but after 3 months, that patient will be back to normal. So if the calcification involves two-thirds of the tendon, and this information I get from the ultrasonologist, then I prepare in advance to do a proper excision and then do a proper repair. And that's very infrequent because it delays the recovery. They want immediate relief in pain and immediate restoration of function. You can achieve that just by removing the calcification. But you must use a horses for courses policy. There's no one rule for everybody.
Okay. Dr. Pritesh bhai.
Yeah, question to Dr. Ashish and other also faculties. Has any time happened that you keep on removing and it has turned out to be a big tear, and then you ended up with repairing it partially?
But why partial? You can repair it completely. It's
No,
not
because
like your conventional rotator cuff tear. It's always a margin tear. So all you need to do is margin approximation. Do not disturb the insertion.
no, when you have
That's
4 by
important.
4 centimeter, and it's a good intra substance along with on the bursal side, if you try to remove it, it creates a very big gap, because it has happened with me once. So in that case, I ended up with the only partial repair. I could not repair
Yes.
fully.
So Pritesh, that's a very dicey situation,
Yeah,
and
that's what I'm asking.
and those ends do not oppose together. You must understand that's a weak quality cuff. So the smart thing to do is do a window near the interval. Now the interval tissue is not so important. You have to factor in which area is your calcification. Either use the anterior interval or use the posterior interval. Create the window, and through the window you pass it. I don't need a more than a 5 or a 7 mm window to let the shaver go in and then remove everything that is required. So it's very unusual to do a proper resection. So this way it helps us
Because
save trouble. I don't
uh,
have to put suture anchors. I just use margin approximate sutures.
Prathamesh,
Okay.
you remove everything. That's a good thing.
Dr. Swarnendu and then Kalpesh. I think both wants to have some say. Swarnendu, go ahead.
Yes, the question was that whether to remove, try to remove the everything. The thing is that when you go inside and you first do the needle in 3, 4, 5 places, whatever comes around with your saver sucker, that only you remove. Don't try to remove it from the intratendinous part. If you want to remove it from the intratendinous part, then you are in problem. That is my opinion.
Dr. Kalpesh bhai.
Yes, Pratmesh, I want to know what was the indication of surgery in this case, actually,
Yes, sir.
particularly.
Yes, sir. A very pertinent question, because it was the patient was very painful, and I believe that the size of the lesion is pretty high for doing any kind of a needling or an injection procedure. and specifically the pain. The pain was very much significant.
Have you tried injection or directly you?
In this particular case, I use injections in minor or specific cases, but in this particular case, I felt it was too much for a injection to take care of. So what is the general consensus among faculty regarding the size?
Most of the time we have observed that after injection with a due course of time, over a period of time, the calcification tend to shrink gradually and it will disappear.
Prathamesh, can we go back to the MRI, take the opinion of the MRI consultant so that we can take the opinion whether from the MRI we can decide whether it is acute or chronic, because that is the most important part for what we have to see in the MRI.
So no, but I agree with Prathamesh in one thing, that the moment you remove this nicely, the patient is absolutely pain free on the next day, and it's a dramatic relief. So with such a big lesion, I will also like to go for arthroscopic removal of the calcium rather than anything else. So I think in this case, because it was a very big calcification.
Okay, now there is a question from the audience. Dr. Rajesh Gupta, probably from Jammu and Kashmir. Jammu is asking, in acute phase, should we go for intervention like needling straightway or give some rest for few days along with NSAID and then intervene? What would be the strategy? Dr. Ashish
Navin
Babulkar,
bhai,
sir. Yeah.
this, if anybody has experienced a calcification, it is the worst kind of pain that you can ever suffer.
Yes.
Even the smallest calcification causes a stabbing pain. Patients cannot sleep. It is typical. It's probably the only DD for a sudden onset pain in a shoulder overnight.
Okay.
And so somebody who has suffered will know. There are few orthopedic surgeons I have treated, and they were miserable. So they demand immediate attention.
Relief,
Now,
yeah.
if that patient takes 3 weeks to come to me, by then the crisis is over. Then they
Okay.
don't need intervention, and then you need to strengthen them, because the only purpose of the injection is to reduce the pain so that they can comply with the exercise program, because
Okay.
with the exercise program they'll get strength. So you are restoring pain and strength simultaneously.
Okay.
I mean, can I have the opinion of the radiologist to have just a small comment how they decide whether it is acute or chronic?
Dr. Dushi, please.
Yes. So we cannot really decide or just on the MR imaging features alone whether it's acute or chronic. We rely on the clinical features as well. Only thing is that in acute phase we'll probably see a little more edematous changes in the tendon. And one more feature that I would like to stress is that it is of utmost importance to have a correlation with an X-ray or a CT scan. Lot many times an MR alone can miss us if there is a small amount of calcification, and which would very nicely be seen on radiographs or a CT scan.
Ma'am, from this particular view, do you find this is acute one? I think there is lot many the signal around that calcification. So what is your opinion? Is it chronic or acute? I think it is acute. I think so far I can understand from
Yes,
the...
there are edematous changes in this particular case.
Yeah.
Here, in this particular case, we do, yes. So there is a little edema in the supraspinatus tendon. Along with that, there is a thin streak of fluid in the subacromial bursa, suggestive of reactive changes. And the extent of calcification is somehow, if it's just the view that that is seen on CT, is lesser. On X-ray, there was a longer extent of calcification that was seen.
Okay, thank you.
Let us move ahead. Okay.
So an painful shoulder is a very common dilemma and scenario in our OPD practice. And let's learn from Dr. Ashish how to examine and come to a diagnosis in these cases, because examination is the key. So he'll be presenting a case on drop arm and how to approach a patient with painful shoulder with weakness. Dr. Ashish, please.
Okay.
Yes.
and there is now one in between. When you start sharing, just start sharing, this screen will go automatically, Dr. Ashish.
Okay,
When you are sharing, there is one question again came.
go on.
What was the line of treatment before the era of arthroscopy and sonography?
Suffer in silence. There's a story I will tell you. There is a story I will tell you if we have time at the end of the session.
Okay.
When we first came upon this disruptive 2005, when I was returned from South Africa, in between the flight, I got this idea that we should start doing needling. And it's a long story. We'll keep it for the discussion after all the talks are over.
Okay,
Let's not
okay, fine.
remind me. Okay.
One of the historical
So-
treatment was iontophoresis. They inject acetic acid into the subacromial space. That I got from the literature review.
Yes.
Very horrible. Very horrible.
Horrible. Right. Let's start with this lady. 45-year-old lady. She has had 2 years of shoulder pain, which she was managing. She's a housewife, and the pain deteriorated since December 2017, and she had poor range of movement, poor activities of daily living. I was not treating her initially; somebody else treated, but this is the history we got from her. But since all of January, she couldn't sleep and she was miserable. So she went to somebody and who looked at the x-ray and who got his oblique x-ray done and then a C-spine done, and they were presumably normal. So I'll spare you all the blushes and we'll just go on further. There is a little downsloping acromion here. The acromion-humeral distance is reduced. Her critical shoulder angle is slightly dodgy. And the MRI was done. This was 30th January 2017. And the MRI reported that this was a partial intrasubstance tear with tendinosis, minimal subacromial bursitis, and some calcific tendinosis of the infraspinatus tendon. Now, this was 30th January 2017. And this surgeon then decided to go ahead and do basically my query here was that we need not subject all our patients to MRIs, because there's a lot of emphasis on the MRI reports and we are led by the radiologist. The radiologist will report what they can see on the MRI. They don't have a clinical perspective, so they do their honest job depending on what the MRI is showing. But MRI doesn't show the tear. It is our interpretation of the MRI that shows the tear. And so these were her features. Now, just to introduce everybody to the features on this MRI, actual MRI, you can see that reasonably okay. This is the subscapularis, infraspinatus coming in, and glenoid looks okay, no OA changes. Biceps is in situ, no great swelling around the biceps, really speaking. And on this also image, the cuff looks okay, really speaking. And if you look here, this is an important image to have. A lot of the MRI centers do not give us a T1 sach. To me, it's a very critical image. And you see, there's no wasting there at all. This is good quality cuff tissue. Teres minor is not hypertrophied. So this is not a chronic case. And you can see the entire cuff tissue reasonably good. There's some edema here on the lateralmost sections posteriorly here. And that doesn't gel out here on this actual image. But these images here, also the stir images, do not show anything exciting here to tell me that this is going to be a dramatic partial cuff tear or something like that. And again, sharing you the coronal images, T1, streaks of fat within the muscle. I don't like that. It's not a good quality muscle. It just suggests. And this is the image where the radiologist has taken a judgment call for a 42-year-old lady that he's seen a signal here. Now, firstly, this is signal which is in the muscular tendinous junction. I am not worried for a 42-year-old chap to have a signal in the muscular tendinous junction. The footprint is completely covered nicely, and that's why it's looking nicely dark. No detachment of the footprint. Looks quite good. In spite of the acromion being so low, that's the biceps tendon coming in. So based on these two features, this gentleman has labeled her as a partial cuff tear. And that's the knee-jerk reaction that radiologists will always report. And I have made this plea with IRI also, that don't label it as a partial cuff tear. You must label it as a signal loss or a signal, high-grade signal within this junction, within that junction. Because for somebody to report a tear, we ought to see a similar tear on the T1 images also comparatively. If you see a tear on the coronal and sagittal and sometimes on the axial, then you know for sure that this could be a cuff tear. Now, having done this compromise, even if you presume that the MRI report was correct, this gentleman has gone ahead and done a manipulation under anesthesia for this lady because she was stiff. Now, he's also given the patient a tricot injection, and so manipulation under anesthesia was done. So now I am going to open this to the house as to what is the likely possibility here for this patient. Where was the X-ray? Right. Can we have opinion, Nishit bhai?
Nishit bhai, unmute yourself.
Yeah, it is the cervical spine was normal.
Normal.
Musculotendinous junction affection. Did you how all the movements were very painful?
Her movements were painful. She came to me after the manipulation, about 3 weeks after the manipulation. But her movements were stiff, painful. She was weak. Night pain was there.
Okay. And what about the ABER and ABIR?
Oh, there is no question about doing that. She wouldn't go beyond that position.
Oh, so that was...
Yeah, everything was less than 90 degrees.
Okay.
She was like a classic frozen shoulder.
Okay.
Radiologist wants to say something.
Yes, please.
Unmute yourself. Unmute yourself.
Sorry, yes. Can we have the MR images again?
Yeah, sure. Yes.
Yes, so here, as you can see, though it has been reported as a tear, I would stress it in my presentation how the coronals need to be taken. The coronals are not in plane with the supraspinatus, and with many centers who do musculoskeletal imaging or shoulder imaging, general centers, they don't have the planning correctly, especially when they come from peripheries. That it is still an issue. Here, if we see that in the sagittal plane, as the cuff it approaches its insertion at the greater tuberosity, there is some amount of edematous changes, but it seems that they are more of edematous changes alone, or there is tendinosis. It's at the posterior aspect, possibly involving more of infraspinatus or posterior supraspinatus tendon. The images that you showed in the coronal plane is more related to the angle rather than being that high fluid signal in the next. Yes, so in the fluid signal, that is more so related to the angulation rather than being that portion being an entire tear. I still would like to defer that there is this bigger tear as much as a fluid gap that you are seeing on the coronal plane.
Yes, Brushi, thank you. I think that's pertinent. I wouldn't quarrel with the sections because, Brushi, some patients are in so much pain that they're just unable to position themselves. And some of the centers don't have a shoulder coil. This center has a shoulder coil. It was a 1.5T image. So we can see the supra coming in here. Kalpesh, would you like to add to this?
Yeah, can you go back to the X-ray slide, please?
There you go.
So here near the lesser tuberosity area, what is this radio opaque shadow that is something?
So that's a calcification.
Area of interest.
That's a calcification.
Yeah.
It's very important pickup because this was disregarded. And that's why sometimes, as I said, that there's too much emphasis given on imaging.
So that was the source of the pain?
Yes.
Well, probably.
Maybe.
You can see here, he has written it on the report. My entire report, he's not given the credibility. So he's not talked about it. You understand? So, so it's like Narendra Modi. You know, he will not talk about unemployment and he'll take your attention off and tell you about 20 lakh crore. So everybody gets excited. So this is the 20 lakh crore here. And
Good, good,
calcification
good.
has remained neglected. But the what I wanted to make a plea in the last presentation, I will make at the end of my presentation. But I think the onus on treating this patient is on us. So just because somebody made an error on the report, or just because somebody was incapable of reporting, and you have no control over who's reporting, we should be able to read our images and ensure that these features are not missed. Now, that's not a true AP. There is no axial, and that is the commonest crime that I see. The one thing to change shoulder practice should be to always take orthogonal images. So you
Yes.
take a true AP, take an axial, and this would have been picked up within minutes. It would have saved her 7,500 rupees for the MRI because
Yeah.
the treatment would be rightly directed.
But
It's very easy
why
to
it is
forget.
not showing on MRI so good, so nicely?
We'll
It
come
is
to
there.
that, Nishit. We'll come to
Oh,
that later.
Okay.
But if you look closely, the MRI is showing you a signal
Yeah.
posteriorly.
yes.
All that signal posteriorly is related to that calcification. Okay.
Yeah.
So we'll debate on that later. Now let's go to the larger question. So the manipulation was done. What do we expect? How do I counsel my patient after manipulation? When is the patient going to get better? How much relief? How much strength? Sanjay Bhai, Sanjay Trivedi.
So manipulation in this case or manipulation in general?
In general, I would say.
In general, I don't like to manipulate ever my frozen shoulder patients. There are most of them, if they are patient enough, with the injection, hydrodilation, and physiotherapy, they tend to get better. And some of them who are in so much hurry, I like to do arthroscopic release after giving them reasonable conservative trial. But some of the alpha males, dominant hand, not able to sleep at night, I tend to release them and they do reasonably well because in manipulation you don't know where you are, releasing the shoulder from the cuff or from the capsule. And I have once in a year I have been receiving manipulated shoulder from periphery with the rotator cuff tears, and these are extremely difficult to tackle. And in fact, the pain and stiffness is so much multiplied. So I would strongly discourage people from manipulating shoulder
Hmm.
uh, randomly and blindly.
संजय भाई आज 8 बजे क्या कर रहे हैं रात को? Please come and address the nation. This is very important statement you have made. It's a very profound statement, and I'm glad we are on the same goalpost, same field. That this is a very. I was hoping you would make that, and you just touched first, because this is what we did. We did an ultrasound, and we found that there was no recruitment. By the time she came to us, the calcification had disappeared because ultrasound would have picked up the ultrasound, but no recruitment of three. They behave like a neuropathy. And let us share her image. This is what's happening to her. She's come in absolute misery. She has become actually worse. So we know, number one, that there are multiple lessons in this case. Number one thing we have to do is we should not do harm to the
Ashish bhai,
patient.
when you start sharing, you included that video clip acceleration
Yes,
and the sound also? No, probably.
sound
That's why
band
it is
kiya abhi.
coming slow.
Correct.
You
Sound
just
band kar diya.
just you stop sharing and again share with the small two
Okay,
check boxes down. Check boxes down there. Share again, no
okay,
issue.
okay. Coming up.
Now there are two check boxes down. No. When you start sharing screen, there will be two check
Huh?
boxes will be there.
Oh, okay.
That
Okay.
you have to make it checkbox right. Then your sound will come. Include my computer sound and
Optimize screen
acceleration,
share.
optimization of your video. Then it will be
Okay.
way
Got
better,
it.
just
Got it.
like in your presentation.
Love it. Love it. Thank you.
Okay.
सीख लिया आज. Got it. So
Now,
this is her presentation. She came to us 2 to 3 weeks after her manipulation. She was miserable. Previously, she couldn't sleep at night. Now she's even worse. And that's a complete drop arm, complete zero movement. And so there are a number of reasons for drop arm. This is one of them. And So I have done many errors, some blunders in my life, but you can never accuse me of doing a single manipulation for any patient. It's something I don't do. And the patients that get manipulated, I have no solution for them because they are very difficult to treat because they're rupture of several tissues which is not under your control, as Sanjay said. So now what? Yeah. For saving time, I think we'll skip the panel discussion because I have one more case to go. Now we
Okay.
put her onto our PSRP exam. Now you understand that she's a very difficult patient. These are her findings from six.
Ashish bhai, there is
Yeah,
some bandwidth problem, so I will stop your video so your presentation will be good. It's blurring.
yeah.
Can I stop your
Okay.
video? Can I
Yeah,
stop
yeah.
your video
Sure.
yourself? You will not be seen, but your
Yeah, yeah.
presentation will be
No
seen better.
problem. No
Okay.
problem. No problem. No
Okay.
problem. Yeah. So 6th of February, she came to us. She had an active movement of 30, 30, 30. So that was absolutely poor. This was complete drop arm. You can see her. She had had manipulation. Her cuff strength was just 3. And so we put her on the PSRP. This is post phase 1. Post phase 1 means she comes to us half an hour every day for 40 minutes. And look at her now. She's gone to 120, 120 and about 20 degrees ER, which is nothing impressive, but we have started from zero actually. What is more impressive is the strength restoration. That is very important. What you see here is she's had stimulation. And if there's a progress in stimulation, she's gone from 42 to 34. That means the muscles have started recruiting. That's a good sign. If the muscles recruit, then she goes prospectively better. This is her. This is her at post phase 1, 14 days. She has improved. Her pain is less. Her strength is less. It took her almost 6 months to improve completely. And so at 6 months, she was completely normal. But this was just a taste of what could be done at the end of 2 weeks. And that is all should have been done. If she had done the same thing before manipulation, that's all she should have done. My query here and my concern here was now there was thing on several fronts. Number one, if that MRI showed a partial tear, surgeon should not have proceeded with manipulation. That's the worst crime to me. If there was calcification, there was no role for manipulation. Even if there's a partial tear or calcification, I think she deserved a trial on a conservative program for a finite period of say 6 weeks, 8 weeks. And should she fail, then you can consider another therapy, something focused, maybe arthroscopy. So the one thing I've never done is manipulation. I used to do quite a few adhesiolysis cases arthroscopically between 2005 to 2010. And the results are very funny. Some patients are dramatically better and some patients are miserable. So I have almost given up doing arthroscopic adhesiolysis. I do that very few and far in between. Our program has become so mature that most of these patients, we do HVI injections and we do rehab. And most of them will take time and get better. So I think that is the sensible thing to do. We'll move on to this case and then I will come to our question about imaging and what needs to be done. This is an interesting case. 50-year-old, my batchmate, but lives in another city about 100 kilometers from here. And he had this severe sudden onset pain over 7 days, which was progressive. It started and then got higher and higher, and then even the painkillers did not give him relief. He has nil comorbidities. His BMI is about 29, slightly on the obese side. And his X-ray was done. And based on this X-ray, he saw a surgeon and who was also his colleague. And they said that you have dislocated this. And so he underwent a close reduction under anesthesia. Post-reduction X-ray was normal. And he was just given a sling initially, but the pain persisted and he couldn't sleep and he had tears in his eyes. So the surgeon then strapped him in this manner. And this was about 8 days since his manipulation. His appetite had gone down. He was not slept for 7 days. And that's when he sent this image to me at that time. So this was his X-ray. Initially, this was his post-reduction X-ray, which looked reasonably okay. And these were his MRIs at that time for his instability. And the report was labrum pathology with no glenoid bone loss. They, in fact, did a CT scan, if I'm not mistaken. And there's no glenoid bone loss at all here. They did the CT scan and absolutely pristine glenoid here. Was quite okay. Now I would like to come to Prathamesh. How do we manage this patient?
Unmute yourself, Prathamesh.
Sir, is the presenting complaint pain or is the instability?
He will not allow us to move his shoulder at all. So he has pain and instability both together.
So can you go to the previous images?
Yeah. Should be an actual image here. Yeah.
Dislocation occurred after manipulation.
No. He had a subluxation
Okay.
here. And then he was underwent close reduction without anesthesia.
And MRI is post reduction after 3
Post
weeks.
reduction, yes. Second day.
Second day.
Was he ED syndrome? Very loose
Come
jointed?
again. Ligament laxity?
Yeah.
No, not at all. Not at all. Not a very fit guy. Slightly on the obese side.
What are tiny tissues visible? Is fluid subdeltoid?
There is fluid. There is a lot of fluid here.
And there are some loose.
A lot of
This is
hemarthrosis you can see.
synovial chondromatosis. Are we seeing it?
No. This is chondromatosis. There is some hemarthrosis. There is some
hemarthrosis. Yeah.
There is some fluid there.
But many times with tendinosis, they have pain.
Yes. No. But this was exposed. He will not allow me to touch him. So I was in his city for a conference, and that's when he called me up, and we met each other at 12 midnight because I went after the banquet, and 12 midnight he had tears in his eyes. So he wouldn't allow me to touch him.
This looks like a hemarthrosis, sir.
But it's not a classic hemarthrosis where, I mean, this is on the peripheral side. There's nothing inside the joint.
Inferior pouch is clear.
Correct. There's nothing. There's no collection. There's no collection. He doesn't have hemophilia. He doesn't have any morbidity, no comorbidity.
Any signs of infection? Any signs of infection?
No infection. Trust me, this is not infection.
Ashish, no trauma? No trauma even?
No trauma. He doesn't. I asked him 3 times. He said there is no trauma at all.
What is the neck examination?
Clinical examination?
Yeah.
We couldn't do any clinical examination. He wouldn't allow
neck,
to touch us.
Cervical
normal,
examination.
Normal. Completely normal.
It's like labrum only.
Subacromial definitely edema is there, sir.
Ashish.
Amanta,
can you go back to the CT scan?
Yes. Yeah.
Yes, I think there is a flake of bone, this glistening shadow around the humeral head.
Yeah.
There,
It's a bone island.
Artifact.
It's a bone island.
Artifact.
Yeah. I wouldn't give it any importance. CT was normal. I've shared you only one image. There are several images, but they were normal.
So what is the source of the pain?
Okay, let's take it. Now, I'm going to refer to this paper. This is a paper called as Unstable Painful Shoulder. This has absolutely no relevance to this case. But the first question that came to my mind was this unstable painful shoulder? This is a paper by Pascal Boileau. The arthroscopists, I would highly recommend that they see this. Pascal discussed this with me in person when I was with him. And it's a very interesting series of about 9 or 10 cases where patients never had injury, never had trauma. They had repeated micro trauma like an athlete has or a javelin thrower has, and they had a labrum tear. They present with pain. They don't present with instability. If you do the instability tests on them, they will have a crank and jolt positive. But technically, the ranges could be either stiff or full. And we have dealt with about half a dozen such patients who have no, but they need to be athlete. There has to be a repetitive micro trauma for them. This gentleman, who's my batchmate, is obese. He's a pen pusher, doesn't do anything. The only time he lifts his arm is to call for a cup of tea. So he's unlikely to fit into this. But the first thoughts that were going in my mind was this a UPS case? And that can happen in the young individual. This fellow's, that time he was 50, is unlikely. So number one is, let's go back to the X-ray again. So as I said, the case I'm trying to make today is sometimes our investigations are way too much and they will take us off the track and we'll lose instance. So this is inferior subluxation. This is not dislocation. This comes with deltoid atony or hemarthrosis. And you can see there's a signal here, which is a flake here. And if you look, not a good quality X-ray here, and you can see that here also. This is again classic calcification. This is classic, but this is amorphous. This is fluid. At that time, if an ultrasound was done and a needle was put in, you could actually aspirate it like a Colgate toothpaste. You don't need to pepper pot it. You don't need to damage it. You don't need to deal with the cuff at all. You just need a 18 gauge needle. And our sonographists will tell us, they get very excited. They said, this is amorphous, start aspirating this. And we would just have to aspirate it. And there's a dramatic relief after that. It is because of the chemical reaction due to the calcification that brings in a microphage activation that causes severe inflammation. And what you see here on the MRI, these MRIs are innocent, but biceps is invariably affected when the calcification is in its neighborhood. So this is typical huge reaction, acute, due to a calcification. The calcification piles on for years, layer by layer, layer by layer, layer by layer. Calcification per se is never painful. It is when that calcification bursts, it is exposed to the blood supply, and the macrophage attack happens. That's when excruciating pain and discomfort. If you have somebody with an acute loss of movement with excruciating pain combination, your first differential should be calcification. So how do we establish it? By the time I see him, he's almost a month late. Yes, go on.
But thing is that if you are seeing that sort of flake in the X-ray,
Yeah.
why you comment that that's the what's flake in the CT scan is an artifact?
But that is not correlating with the area of the.
No, but
Yeah, of course,
calcification.
it is not
So
dynamic.
just
Of course, it
Ashish
is.
bhai,
Calcification is in the supraspinatus. The
Sir,
flake you're
sir,
seeing is a
Ashish
much
bhai,
inferior level.
Ashish bhai,
Yes.
just to brief you, there are so many
Yeah.
combinations the audience has thought. Probably it's a glenoid fracture. Don't you think it's a cuff avulsion?
Right.
A small flake of bone with
Ashish,
cuff,
why-
probably it is a GT avulsion. So many people are seeing the X-rays and they are
Correct,
reporting
correct.
this.
Ashish,
Let
why
me tell you
biceps
something.
is more affected? I mean,
Always,
why
because
biceps? What
usually
happens?
biceps, whenever the calcification is either superior subscap or anterior supraspinatus, this is the neighborhood syndrome. So both these structures are bisected by the biceps. When there's a pathology in the neighborhood of biceps is very vascular. So it will react and will be inflamed all the time. If you have a posterior cuff calcification, it does not mess with the biceps, and biceps is pristine always. So I wanted to make a comment during Prathamesh's presentation, and I withdrew my comment. The comment I was trying to make is, please do not do an MRI for calcification. You will be taken for a royal ride like this patient. He suffered for a month unnecessarily till he could come back to see me. The only ideal examination for calcification, if you suspect that on an X-ray or clinically, is an ultrasound. Ultrasound cannot miss it. Now let's step back and look at how does an MRI diagnose a condition, or what does an MRI do? MRI is proton based, and so it's based on the tissue presence of water, fluid, edema. A calcification is completely dead, and so an old calcification, if it is small in size, the MRI will miss it. This was not small in size, but it was amorphous, and it was littered over the subacromial area. The CT and MRI both missed it. Supposing you send a patient as calcification for an MRI, that MRI radiologist is invariably going to subject that patient for a CT scan because they are not confident. You saw the discrepancy between the X-ray, which showed a 4 centimeter calcification, and MRI showed only a less than 2 centimeter calcification. So they will subject it to a CT scan. So additional expenditure, exposure to radiation is uncalled for. So medico-legally also, and whatever, do not go down that path. Your trusted investigation for a calcification is ultrasound. You'll never miss it. And this is the golden rule that MSK radiologists will tell you all the time. That's very simple. So this patient, we sent him for a ultrasound. We picked up the calcification. So the calcification is above the humerus, just as the supraspinatus goes and inserts in here, and about 10-15 mm, and severe inflammation. All we did was needling, put him back into a 6 days rehab program, and he did well. He did incredibly well, and within a month he was fine. So few tips for all the audience here. Number one, any pain that is sudden onset, any pain that is associated with the pseudo paralysis, whenever the pain is disproportionate to the X-ray or clinical finding. I don't know of any condition that will come up with overnight pain like a calcification. It is a stabbing pain. Those of you who have experienced it, it is the worst pain that you can ever. Patient will demand surgery. That is the only condition as such. So please stick to an ultrasound. And my other recommendation was that if a patient of frozen shoulder comes in, let's not jump to an MRI, because that MRI will report partial cuff tear. Then somebody will go in for surgery. He will get more stiff, because today full thickness cuff tears are not challenging to treat. For me, treating a partial cuff tear is very challenging. But a partial cuff tear reported by MRI and a structural partial cuff tear are completely different. MRI will show you the signal. One of us will interpret that signal as a partial cuff tear like the first patient. So our radiologist, Dr. Patel, was very clear in saying that that signal that you saw in the first patient was a high signal musculotendon junction. It was an angle signal. It was not related to any structural tear. And if you are looking at a tear, you must see the tear on MRI, on coronal and sagittal images, both in the same situation, anterior, anterior, or posterior, posterior. Then it becomes a tear, and then you might want to treat the tear. But somebody who has a small tear, give them a rehab. It's unnecessary that both these patients had to suffer. The entire take-home message for today's patient was that you must do a clinical assessment. The assessment, diagnosis, and treatment is decided clinically. I will only confirm that clinical assessment on my investigation if I need it. Our intention to do in MRIs is probably in 10 or 15% of our patients. 80-90% of patients will be treated on a clinical judgment. And if that doesn't work, you can always do the MRI at the 2-week mark, depending on somebody who's deteriorated or not gotten worse. The last statement I want to make is we all should understand to make a distinction between a functional pathology and a structural pathology. Those who are really driven, inspired by this, should read Vladimir Janda, who was a fantastic neurologist from Czechoslovakia, and a lot of our work is inspired by him. By functional and structural, what I meant was somebody who has impingement, somebody who has scapular dyskinesia is a functional problem. Don't do investigations. You will not find it till such time that you're looking for a slap tear, rotator cuff tear, labrum tear. That MRI is going to come up with a vague report, and it's a page full of report, and you're reading through it and you're like clutching at straws. I don't understand what's going happening here. Patient is in pain. So these are functional conditions. Like your patellar pain, like your anterior knee pain is a functional problem. When that gets neglected and for years it goes on continuously, and then after 5 years that patellar pain comes with a cartilage lesion on the odd facet medially, and then patient cannot squat, then that becomes a structural problem. And then that MRI is useful, then that X-ray is useful. So a lot of the patients come to us in the functional stage. They absolutely do not need any kind of CT and MRI. So let's be objective. Let's be very frugal in investigation. Let's improve our skills on clinical examination. Although my talk should have been on clinical examination, it's a lengthy 40-minute talk. We didn't have the time to do that. But those who want to can go on my website and download my presentation on shoulder examination so that they can complement today's presentation with a proper shoulder examination study.
Okay.
Thank you very much.
Dr. Ashish, there is one question only from me.
Yes.
Do you find anytime any triggering event to release of that chemicals or busting of that calcification?
Yes, not always, but there is a certain where they go and they have a jerk. So
Okay.
they are lifting something heavy and that object drops, and that's a minor jerk, and it's a trivial jerk. You ask them, they will not remember it. They will, you have to dig deep and ask them, ki, what is the jerk that they faced. Number two, the patients who are hypothyroid,
Please make
the
your video
patients
on. I made it on, sir. Please make it on so that we
okay,
can see
yes,
you.
yes,
Yeah.
yes. So most of the
Triggering.
patients who are hypothyroid, comorbidity will not have a trigger at all. But there's a once the calcification becomes of an X size, like 2 centimeters, it is likely to spontaneously burst. Often it bursts in the sleep also. It's that inflammation you treat. If that patient comes after 4 weeks, the inflammation is gone away. I don't do any form of needling. I don't do arthroscopy. My incidence of arthroscopy for calcification is 1 in 50 patients. 49 patients will undergo needling or direct rehab. If they don't have pain, you don't need to do needling or intervention. They just can go back to the rehab program because the intervention is done to allow recruitment of the muscle during rehab.
Okay, it's a decompression you are doing only. That decompression is required of that inflammatory condition at that time. Needling.
Probably.
Yeah.
Probably.
Okay. Now, Prathamesh bhai, who is sharing?
Yes, sir. So now we'll just be presenting a small case. A 50-year-old patient. He presents with a painful shoulder and inability to lift the arm, and with a terminal restriction in the movement. So I'd like Dr. Drushi to please comment on these MRI findings, and then we'll just ask with Dr. Kalpesh how will like to manage this patient.
So this is a ultrasound image, and this is an MR coronal image. The ultrasound image, both of them, they show a partial thickness articular surface tear, approximately 50%, involving the distal supraspinatus tendon, with minimal retraction of the tendon fibers.
So for this particular patient, the options can be rehabilitation, guided injection, arthroscopy and debridement of the tear, and arthroscopy and repair of the particular tear. Let's go to Dr. Kalpesh and see how will he manage this particular case. Dr. Kalpesh, please share your screen.
Kalpesh bhai, you are not seen. Hello?
Kalpesh is not there.
He is gone.
So we'll just
move to next.
We'll just go to the next case. He's a 55-year-old patient. He presents with pain in the shoulder for the last 2 months. It is accompanied by severe stiffness. He has no history of diabetes. There is no history of trauma. Both active and passive range of motion is restricted. He is in severe night pain. He is unable to sleep in the night. The sugar levels were also not very much controlled. And when we go, we saw these pictures. The X-ray was normal, and these were the MRI pictures. Dr. Drushi, can you please comment on these MRI pictures?
Yes, the first image is a sagittal image. It shows synovial inflammatory changes at the level of the rotator cuff interval. There is a thickening of the axillary pouch, and along with that, there is a mild thickening at the level of the coracoacromial ligament as well, as all these arrows are pointing. So these are classic findings of adhesive capsulitis that we see on an MR image.
Okay, so now let's the treatment option in this particular case will be rehabilitation, intra-articular injection, the newer therapies like hydrodilation and arthroscopic release. Let's go to Dr. Nishit sir and see his opinion about how he like to approach his patients with adhesive capsulitis. Dr. Nishit, please share your screen. Nishit sir.
Is my screen is visible?
Yes, sir.
Huh?
Yes, sir.
Okay. So as I understand that we have already discussed that this patient, first thing that we have to get a rehab done with a better control of diabetes, and but most of the stiff patients, and this is what we all know about the frozen shoulder. There is a 3 phases: a phasing phase, which lasts for around 3-4 months. Then you have frozen phase, where the joint becomes painless almost, but it's very stiff, and the patient attempts some movement, then it becomes very painful. And then you have a thawing phase or remodeling phase, which goes up to 18 months, and then becomes and this is what we are all taught, that at the age of 18 months, 24 months, the patient will become all right. But these are the 2 papers that I come across, and they were published almost before 25-30 years, and they said that the patients become all right between 39 to 55%. There are many patients who have a relative objective stiffness, objective range of movement loss, which we are able to appreciate though the patients are doing good work, their stiffness is still continuing, their problems are still continuing, and that is after 18 to 24 months. So we have, and we all have observed that by that time the supraspinatus infraspinatus weakness, and there is a lot of scapular dyskinesia, which is having problem, and rehab becomes a problem. So, and as Drushi has already said, that the whole problem is in the coracohumeral ligament and the superior capsule region, and invariably it is an anterior capsule that is affected, including the axillary pouch in a frozen shoulder. So, and in the idiopathic population, 5% of the normal population gets this, and 1 in 5 diabetics are likely to get this frozen shoulder problem. So it is a big problem. The treatment that we have been doing is conservative, and I am sure that everybody of us has seen this patient having 1 month, 1.5 months of shoulder physiotherapy. I'm not talking about PSRP here, okay? It's a different ball game, but for most of the physiotherapists, this is what we have seen. And then we have other gamut of thing is arthroscopic release, which everybody of us, as Ashish told us, that it is a very rare, but we have to do it because we have felt it very safe. So where this hydrodilatation, I'm going to talk about hydrodilatation, where it comes. So it comes in the first two phases, where in the freezing phase, and I would like to do in the freezing phase, and in the frozen phase, uh, once all the other treatment has been done, proper treatment has been done, like and all the investigations are done, and the patient as having a good control of diabetic. So hydrodilatation, how it works, it works and there are all hypotheses that it is a mechanical resolution, so capsular deformation, though there we usually hear pop while doing this only in 30-40% patient, not in a great number of patients. Still these patients, they improve with the good physiotherapy. And the one theory is that it decreases glycosaminoglycans concentration in the joint capsule, which reduces the myofibroblastic activity, and it heals the joint capsule in a stretch position. This is what the whole have. And how do I do it? It can be done without anesthesia, but in my cases I usually like to do under interscannal block for the postoperative pain relief, or under GA. IITV is not a must for me because I am able to go in the joint. But if there is a obese individual, I would like to do is, I do not have any experience with ultrasound assisted injection. Usually it needs 40 to 18 cc of normal saline, and at the end of the procedure I would like to put a steroid with sensor cane, and I believe in prolotherapy, so I also inject around 8 to 10 cc of dextrose injection, and patient is back to home in 3 to 4 years. These are the common requirements to do this hydrodilatation procedure, uh, which is very available anywhere, and it doesn't need anything very expensive or very sophisticated, and only need you might need is a IITV. So this is what how I do it. Hydrodilatation and gentle manipulation under anesthesia at the end of the procedure. So first thing that this patient is under general anesthesia, and you have to locate the, you take all the due precautions, and this is what once you take it, you put because the patient is under anesthesia, uh, and the first time you inject is around the 10 cc, it goes very easily, and you can see that the reverse saline flow is coming out of the joint. And then when it becomes, it really sometimes you have to do a very hard work, and suddenly you will hear a pop sound when you are beyond 30 cc 40 cc's, and suddenly you will feel that the whole resistance is gone, and your injection goes in very easily, and the fluid coming out of the joint also reduces, and at the end of the procedure, as I said, that I put this cocktail, and then because I have already heard and I know that it is, I start doing side gentle shoulder manipulation. As you can see here, this lady never had any ABER and ABIR movements, and you can see that still it is the ABER I am able to get on table after this, but still the ABIR is a problem. So I asked my anesthetist to put the hand, and I just try to do it slightly more, and this is what the and then after cross have abduction to stretch the posterior capsule. So this is what in my case the hydrodilation with manipulation is, and this is what and of course she also gets a good physiotherapy at home. She had this problem before for 2 months before coming to me, and with, so this is what the scapula exercise with scapula stabilization. I like to do a prone exercises, uh, so the capsule is stretched and scapula is stabilized, and this is 1 week after the surgery. I mean after the procedure, it's not the surgery. This she had you can still, there is a still lot of scapular kind of dyskinesia, and from her this was the internal rotation within 1 week of the procedure, uh, and then she was seen at around 2.5 weeks post procedure in my consulting room. That was for 2 days. This is what right. Still she's under rehab, and but this was she was able to achieve. The lady who was not going, this was the internal rotation that she could achieve within 3 weeks, less than 3 weeks. So there are of course the contraindication. I will not go into details, and this is few papers that I could get out, that yeah, I could see that this was after 2 years. They said that significant improvement in all measures. uh, there was deficit in the shoulder functional capacity as examined by the surgeon, but patients were very happy. Only thing that they excluded the diabetic patient. The another patient, another study which was in 51 patient, they also said that similar outcome in diabetic and non-diabetic with this hydrodilatation, and it was very effective. And this was a mega study with different outcomes, but all the outcomes have shown that if it is done in a proper manner, then the hydrodilatation with steroid or without steroid is a very effective procedure in most of the patients. So I think that is a self and well tolerated procedure. It's a minor adverse effect. I am very afraid to do any manipulation because I there is always I'm afraid of doing a fracture. Uh, Capsule pop you see only in 30 to 40 patients, but post-op improvement is there in all the patients, most of the patients. First of physiotherapy, supervised physiotherapy is very important, and it takes around 2 to 3 months to improvement period, because first you get the movement and then you get the shoulder rehab, a proper shoulder rehab with getting the muscles back into the action. And I think there is a rapid non-surgical and economical treatment which is available to patients, and many patients they accept it, because when we talk about arthroscopic release, many patients are not ready to undergo surgery. Thank you very much.
May I ask one question?
Yes.
It is only hydrodilatation, or you go for rupture of the capsule also? Because
No, only in
way
30
back,
or 40% of patient you are able to see the you are able to feel the pop, actual pop, like something has given way, but
so
not all the patients.
you expect this pop, or you go for hydrodilatation only?
Pardon? Sorry.
You you are going for this pop, or
No,
you go for
hydrodilatation only.
hydrodilatation only?
No, if I get PEP, I'm very happy. But if I do not get POP, still I am able to stretch the capsule, and these patients they do very well, because these patients already have uh, undergone a lot of rehab. No, we do not discuss about whether a proper rehab or not. but the rehab that is currently available market, they have undergone and they have not improved.
In literature, distension insufflation has been given the name Brisment. This is under the topic of Brisment. So you feel that this hydrodilatation is working or your cocktail is working?
Uh,
Hello.
the mega study, they have shown that there was no difference in the patient with the steroid or without steroid with the hydrodilatation. So I think the hydrodilatation is working, not the cocktail.
Okay. Dr.
Oh.
Sanjay Bhai has, Trivedi sir has some to say, and then the Pritesh Bhai. Okay.
Thank you very much. Nishit
Meanwhile,
bhai, excellent.
Kalpesh Bhai, you can start your sharing, or if you want to give again introduction, Dr. Prathamesh Bhai, you can give
Yes,
the
sir.
introduction of the case, because Kalpesh Bhai has now joined with a good internet connection.
Okay,
So,
Sanjay, go ahead.
uh,
Sanjay bhai.
Nishit bhai, excellent presentation, and you have shown your way of doing hydrodilation. I would like to say to Dr. Chaudhary that the principle are two for this treatment of adhesive capsulitis. One is you distend the capsule to the maximum possible extent, and at times it ruptures. In general anesthesia patient, whatever rupture and all you can sense or pop you can hear. My technique is to do it in an awake patient and do not rupture. I just distend it to the maximum tolerable pain extent, and I always add some 80 milligram of triamcinolone into it, because most of the time these patients for hydrodilation come to you only when their night sleep is disturbed and there
Yes.
is intense inflammation. So the initial intense inflammation is taken care by this steroid, and hydrodilation does stretch out the capsule, and it is not to be manipulated in my case at the same time, or never to be manipulated. The gradual steady improvement in the range of motion by self-administered physiotherapy, initially in a supine position with scapula stabilized, and then in the sitting or standing position. That is how we approach to it. So it is immaterial whether pop is intention or steroid is working or not. This is the matter of a conservative treatment of adhesive capsulitis, which on itself also can resolve during a course of time, and you are just trying to shorten the course of disease or course of suffering by the patient. That is your intention.
Okay.
Absolutely, absolutely.
Pritesh Bhai,
Yeah, I agree with Sanjay Bhai. I also do in the sitting position, conscious patient, but my approach is posterior portal.
just keep
And
your mic nearer to your mouth so that everybody can
I
hear you.
always go from posterior portal. And I initially started with sodium hyaluronate along with this triamcinolone because there are patients with chondropathy. And then I got tremendously better result.
So now
Patient,
the question to both is Sanjay Bhai and both, you mix up the steroid initially from the whole
no,
saline, or you
I, I go for,
Included this in my talk actually in my
I
discussion.
inject first depomedrol followed by saline or sodium hyaluronate, whatever you are using. But I don't
How
mix it
much you
up.
are able to put with this?
Sorry?
How much you are able to?
I am putting
volume.
8 cc. 8 cc.
Is it enough to stretch the capsule?
But we get a tremendous result. So
No.
I don't know how
Okay.
many, because it's more than 250 patients I have
No, but
treated, and superb result. They
Navin
improve.
bhai, I have included this thing in my talk actually.
okay.
Okay,
I
Bhai.
think
Yes,
we should
that's
go
that's
ahead with the
We'll
yeah,
go
yeah.
Kalpesh's
with
talk.
that. But there is only one question to the Nisit Bhai. The question is, while you are doing manipulation in your video, do you support the elbow, or you hold it with the only forearm? And how many chances of fracture or hydrogenic fracture? That is the question someone has asked.
No,
In
I
your
have not
video,
suffered
in
any.
your video, you have not supported the elbow probably.
No, I was supported because I want to move the shoulder all the time. So most of the
Okay,
time I'll but when I do a full abduction, I'm not supporting the elbow because at that time I want the shoulder movement to done.
okay,
And
okay.
and and I have not suffered any fracture because I am very careful about selecting the patient. And second thing, that I do not want to do any manipulation without doing hydrodilatation. I first thing I always do is hydrodilatation, and then, because for us most of the time the patient comes only once, so we want to do both the things together, manipulation and the additional procedure. So this is what I do in my setup and
So,
my
what
practice.
should be the message? What is the absolute indication of the manipulation if it is to be
So
done? I think there is no condition where manipulation is to be done. That was the message previously.
see, the thing is that if you can get a very good physiotherapist who understands the shoulder, and if they can do a good physiotherapy, and as Sanjay has said, that many patients, they are having night pain, and we have seen a miraculous recovery with this therapy for the night pain. I mean, I was shown this lady who has not slept for around almost 1 month at night, and within 6 weeks, within 4 weeks, she has almost full range of movement with a good night's sleep. So I don't think that we need to have any uh, uh, studies for this. This is the clinical study,
There,
and this is not the first patient. My friend, the Manoj Mehta from Baroda, has done around 100 patients, and he is
Okay.
also very happy, especially with the diabetic patients. And so this is what I think, that this is a important therapy for a frozen shoulder
Now
to,
there is a,
for us
there
to
is a
consider.
one there is a one
Take
question for
home
Dr.
message.
Assis,
We'll take
that
home
what
message.
is your opinion about the hydrodilatation? Assis, are you there? Dr. Assis?
Sanjay, we have
Hi.
some question.
Dr. Assis, yeah.
Yes,
No,
I had raised
What
my
is your
finger. I
opinion
didn't
about
realize
this?
my. Yes, I got the question. I had raised my finger. Two things,
here
Nishit Bhai. The
here
classic hydrodilatation does not involve manipulation. Number one. Number two, we have switched to a technique called high volume injection, which is approaching anteriorly and involving the CHL only, the coracohumeral ligament. We do not invade the joint. So I don't like invading the joint like that in a OPD setting. There's a very important English study, British study, that I will share with all of you. They did 20 normal patients, not stiff shoulder patients, 10 radiologists and 10 surgeons, and asked them to inject a contrast into the shoulder by whichever their portal. Some did anterior portal, some did posterior portal, and only 3 radiologists and 4 surgeons could enter the joint. So whoever is doing any form of hydrodilatation, to ensure that your injection is reaching the joint, you must use an ultrasound, because then you know that it is going where you want to go. In a normal shoulder, they were struggling. In a stiff shoulder, these are adhesive capsulated patients are very stiff and painful. So if you complement your technique with a ultrasound, it will make much more sense.
May
Okay,
I?
Dr.
point
Sanjay B
point
has some
taken,
input. Okay.
Ashish bhai, point taken, but we don't have wives.
Oh, you can have a second wife.
So,
Wish.
Navin bhai, to clearly answer the question about manipulation, the bottom line is you should never. But
Never.
this is general orthopedic surgeon population,
Yeah.
which we are trying to address. So, if we divide this frozen shoulder in three categories: freezing, frozen, and thawing, I would strongly recommend, if you attempt any manipulation at all, you try it in first 3 months, which is the freezing stage. But irony is, in that phase, no patient would agree to you for a manipulation. So, practically it will translate to zero manipulation. But that is the only safe phase, freezing or early phase or first 3 months, where one should, if at all manipulate.
Kalpesh bhai, okay.
yeah. So I definitely agree with Sanjay bhai. And whenever you want to do manipulation, it is always short lever arm manipulation. And please avoid the high risk cases like elderly individual, particularly elderly ladies with osteoporotic bones.
Okay. Now, I think you can go ahead, Kalpesh bhai.
Yeah. So my topic is injection techniques, and if you see broadly, the shoulder injections are divided into diagnostic and therapeutic. Now we all know that shoulder conditions are very specific,
and most of the diagnosis is made by clinical examination. But many times we see that the conditions are overlapping. So even if suppose the patient is having a rotator cuff tear, he might be having a acromioclavicular joint arthritis also, or some biceps lesion also. So when you want to know whether the pain is coming from the biceps tendon or from the acromioclavicular joint, you can use these shoulder injections for the diagnostic purpose also. Whatever may be the reason, but it should not be taken lightly. Strict aseptic precautions are to be maintained to avoid disastrous complications of infection. Number one, I would like to make this point very strongly. Written informed consent is mandatory even if it is diagnostic or therapeutic. And beware of diabetic patients, because when we use steroid, we all know that it hampers the glycemic control. So proper control of diabetes, the blood sugar level is absolutely essential, and you have to take this group of patient particularly in great detail. So regarding this diagnostic injection, whenever there is diagnostic dilemma, just inject with 2% xylocaine and repeat the provocative maneuver. So whenever the pain is reduced or less, you can definitely come to the diagnosis that this is bothering the person. Now, this is very important when you do a surgical intervention. You want to check whether I need a Mumford procedure or some biceps stenotomy or tenodesis along with that you can, as a diagnostic injection, will be of great help actually. Now, most common indication is injection is a person with rotator cuff disease, and we need to answer this question: when, where, why, how, and what. So we'll answer one by one. Now, if you look at this slide, there is rotator cuff tendinopathy or dysfunction in form of tendinosis or a tear, which will eventually lead to mechanical subacromial impingement. Eventually, it will lead to compression of the subacromial bursa between the rotator cuff and the acromion, which will increase the bursitis and pain, and this is the vicious cycle. Now, if you look at this particular figure, this is the coracoid process, coracoacromial ligament and acromion. This is the coracoacromial arch. And when person wants to do a forward elevation, this inflamed tendon or tendinosis will traverse through the coracoacromial arch. And what is the function of the injection is to reduce the inflammation actually in the tendon, so that you break the vicious cycle, right? So most of the patient having tendinosis or partial tear, they are treated with a structural rehabilitation program, which includes the recentering of the shoulder, strengthening of the rotator cuff, and correction of the scapular kinematics and postural abnormalities. Now, these patients with a tendinosis or partial tear, their symptoms or pain is not severe enough to undergo the surgery, but their symptoms are severe enough to hamper their day-to-day activities. And most of them have a night pain, and impingement tests are positive. So these are the patients who need injection to relieve the pain, to break the vicious cycle of impingement and tendinosis, and so that they can get the benefit of the rehabilitation. And 90% of the patients, we have seen that with a good rehab structure program, tendinosis, they get better with the rehabilitation. Now, where? Second question, where? Most of the time, the injection is in the subacromial bursa. And for the subacromial bursal injection, my approach is always posterior. And this is the drawing. This is the posterolateral corner of the acromion. You palpate, go 2 centimeter inferior and 2 centimeter medial, and insert your needle. In normal patients, the thin and lean patient, routine build, 1.5 inch needle is sufficient. But if the patient is bulky or muscular, you have to use the spinal needle. You direct your spinal needle little bit castellated and laterally pointing towards the anterolateral corner of the acromion, and you inject your bursa. Now, volume is very important here. At least 10 ml of the volume is important to infiltrate the bursa all around. And with this injection, your aim, why, is to reduce the bursar inflammation, pain relief, and then patient get to go for a better rehabilitation. Now, there are studies that blind injection, 76% of the accuracy is there. And we have seen in bulky patients or in muscular patients, sonography guided injection really helps. So here you can see very nice sonography guided injection is placed and the injection is delivered. This will reduce the chances of the intratendinous injection, and definitely it will help. The USG guided injection in certain situations will help. Now, third question is what? Now, corticosteroid has been used for the subacromial injection since years. It is very cheap. It has a strong anti-inflammatory action. The dose usually studied is 40 milligram is enough. They have studied that 40 milligram in 80 milligram patients, there is equal effect. So 40 milligram of triamcinolone with 10 ml of the 2% xylocaine is the injection volume we need to give. There is no consensus in the literature regarding how many injections, but it is shown that to avoid the deleterious effect of the steroids, single injection is usually sufficient. At the most, you can use 2 injections, but one should avoid using multiple injections particularly. Now, there are disadvantages of steroids also. It inhibits collagen formation both in the cartilage as well as the tendon. The intratendinous injection will lead to tendon degeneration, weakness, and eventual rupture. So, intratendinous, intra-cuff injection has to be avoided, and USG will be of immense help in this condition. Usually, they have alter glycemic control. So, a diabetic person, you have to be really cautious. The second molecule is hyaluronic acid, hyaluronans. One thing is certain from the literature, it doesn't harm, it is not harmful. Usually it's a viscoelastic joint lubricant property, but here we do not want this joint lubricant or viscoelastic property to act. But there are enough mechanical and biochemical studies are there that it will reduce the effect of the proteoglycans and inhibit the prostaglandin and IL-1 synthesis. There is a strong anti-inflammatory effect also. So our indication is in young patients, particularly when you want to do repair, when you want repair to be done and the person is not ready for the repair or you want to delay the repair, hyaluronic acid is a good choice. Third substance very much in a vogue right now is a platelet-rich plasma. We know from the use of the tendinopathy, its use on the tendinopathy like tennis elbow or Achilles tendinitis, that PRP contains very high concentration of the growth factor, which eventually leads to increases the healing response. And particularly for the shoulder, PRP, there are no enough trials to suggest that it is of more help than the steroids. But when you want to use PRP, it's usually the leukocyte-rich PRP is important to use because of its anti-inflammatory effect. And my indication is particularly partial thickness articular surface tears and the interstitial tears. And I inject intratendinous PRP, USG guided 100% to be sure that I'm injecting to the right site. Now coming to the glenohumeral injections, what are the indications? The most common indication is adhesive capsulitis or frozen shoulder. And as we know from our experience from the literature that the idiopathic adhesive capsulitis or frozen shoulder, it's an intra-articular problem, inflammatory fibroplasia of the capsule, and the intra-articular injection is indicated in case of the acute phase. There are 3 phases as described by Sanjay recently. So in the first phase or acute inflammatory phase, whenever the pain is severe enough to hamper the day-to-day activities or severe night pain is there, to break the pain cycle and to facilitate the physiotherapy, you can inject intra-articular in case of the frozen shoulders. Now, there are enough studies available that it doesn't show that if you inject volume is immaterial actually. So if you inject, do hydrodilatation, or there are certain studies which say there is equal effect of the intra-articular injection and hydrodilatation. Second indication is primary osteoarthritis of the glenohumeral joint and rheumatoid arthritis. Now, I would advise you to use the steroid injections, particularly in these conditions with very very caution that it is shown in the literature that multiple injections in osteoarthritis can lead to high chances of the post-operative surgical infection when you go for the total shoulder or reverse shoulder replacement in this patient. So you have to use judiciously. Regarding the glenohumeral injection, there are two approaches, posterior approach and anterior approach. Posterior approach is the same point from the posterolateral corner of acromion 2 centimeter down and medial, but you here they direct your needle to the coracoid process, and you always use the spinal needle, long one, to get into the joint. Now, when you use this USG guided posterior approach is okay, but when you use the blind injection, I think anterior approach literature has shown that the chances of getting in the joint are more with the anterior approach actually. So just medial to the coracoid process, you introduce your needle, the direction should be posterior, slightly lateral and cephalated. And you get loss of resistance and you can inject very nicely without any USG control here. But definitely USG guided glenohumeral injection gives 100% accuracy. And this is the view here, your probe is there and this is the humeral head. In this region, you have to see the movement of your tip of your needle, and then you can confirm the intra-articular position and go ahead with the patient. Third indication is the acromioclavicular joint AC joint injections. Primary or post-traumatic AC joint arthritis or distal clavicle osteolysis. It's a degenerative process where you find the painful inflammation of the AC joint, and on X-ray you find that distal clavicle is osteolysis. So you can use either sonography guided or a blind injection from the top. You infiltrate the local anesthesia and then you insert your 18 gauge 1.5 needle. If you hit either a clavicle or a part of acromion, and by tactile sensation you pierce your acromioclavicular joint. Actually, when you inject the acromioclavicular joint, it cannot accommodate more than 1.5 to 2 ml of your injection volume. Another important thing is the biceps injection. Many times in overhead athletes, we have seen that they come present with the lesions of the long head of the biceps. So when you inject sonography guided in the sheath of the biceps tendon, the xylocaine, and the provocative signs are normal or pain patient is pain-free, you can use either diagnostic or therapeutic injection in case of the long head of biceps tendon also. These are the post-injection instruction: rest in supine position, observe the patient for 30 minutes, don't allow him to go out immediately, and warn them that pain might increase for first 24 hours, avoid strenuous activity for 2 days, ice application and NSAIDs. So with this, I conclude my presentation and is open for discussion.
Thank you, Kalpesh bhai, thank you.
Yeah.
Any value addition or anything different from any faculty? Meanwhile, there is one comment for Dr. Ashish bhai from Dr. Praveen Sarda from UK. Thanks, Dr. Babulkar sir, for making important point. Patient with suspected frozen shoulder and calcific tendinitis should never be referred for MRI. Totally unnecessary. That is one comment has come from UK. Yeah. And in one of the presentation, they said that manipulation, injection, hydrodilatation, all three are done. Which is working? That is not clear cut with the audience. Is there any literature review or any opinion or consensus which one is working? Which should not be done, which should be done? Manipulation, I think your message has gone. But you are unmute yourself. Unmute.
First thing is rehabilitation. The rehab is the most important, but proper rehab is most important. And then if it doesn't work, then I think in my case, I would go for hydrodilatation.
Okay. Navin bhai,
then if
Ashish bhai, please.
Everything works in combination if I am in a hurry. Now, manipulation has also worked. I'm not denying it doesn't work. But the complications that manipulation can cause can be lethal and we will introduce harm to the patient in a small percentage of patients.
Okay.
When we have an improved academic program where we have better rehab solutions, I think we should spend a good 2-3 months on rehab, find out what is better. There's a very nice article on Scandinavia on about 800 patients, double-blind randomized study on home rehab versus manipulation. And quite categorically, p-value is significant. The home rehab patients over 6 weeks did much better than the manipulated patients. So it is not that there are no other alternatives. So to each his own, find out what works in your hand. But whatever you do, ensure that you don't create more harm for the patient. At the end of the day, patient should go home with a better function, not worse.
Okay. First principle, do not harm.
Yes.
Yeah. Now, who is going next, sir? Prathamesh bhai, you're muted yourself.
Yes.
Yeah.
So we will be just seeing some salient features in the MRI by Dr. Drushi. She'll be just focusing into the MRI features, salient MRI features on the, as far as the rotator cuff pathologies are concerned. And because this is a very pertinent problem for all orthopedic surgeons who are in general practice, the patient will come with the MRI report and just important things to what to look for in the rotator cuff pathology. Dr. Drushi, please.
Thank you, sir, for having me. So yes, I'll be talking about imaging of rotator cuff. This is going to be a lecture rather than a discussion. And what I intend to do is show you the imaging modalities for rotator cuff, and then discuss how an MR shoulder should for rotator cuff should be read, and then a few salient features. Now, radiographs, as it has been stressed in the previous discussions, that you cannot ignore the radiograph. That is probably the first investigation that is to be done, and that has to be available wherever possible, even when we are reading our MRs for correlation. For rotator cuff per se, soft tissues cannot be seen, but the acromio-humeral distance, which is normally 8 to 12 millimeters, is an indirect sign to in rotator cuff injuries and chronic tears. This distance is reduced, as is confirmed on this MR. Acromioclavicular joint hypertrophy is seen on radiographs and is responsible for subacromial impingement. Calcifications that we have extensively discussed are much better seen on X-rays or the radiation-based modalities, sonography also. And MR can miss these calcifications. Ultrasonography, it's an excellent tool for evaluation of rotator cuff. Dynamic evaluation is possible, only that it's operator dependent, and it cannot evaluate when there is significant retraction, where the torn fibers are, if it is more medially retracted. And it is not objective. You don't have objective films to correlate and later have an opinion on. I am more of a MR person, and that is what I practice. So I'll be stressing more on MR shoulder, which is an investigation of choice for shoulder. We'll look at the protocols and sequences, MR anatomy, how we read MR shoulder, and then see the spectrum of findings in rotator cuff tears. So patient we have in a shoulder coil in a supine position and properly positioned with sandbags and tapes in place to avoid motion artifacts. A typical imaging protocol just needs 4 important sequences, 3 of which are a T2 or a PD fat suppressed images in all the 3 planes, axial, sagittals, and coronals, and at least 1 T1 weighted sagittal oblique for evaluation of fatty atrophy, where the muscle bulk is nicely seen. And it is very important that we plan these coronal obliques. These are not routine coronals, these are coronal oblique images. And they have to be planned parallel to the supraspinatus tendon. When this planning is even a little offbeat, it is possible that it is not seen in view, and it can give false appearances of tears because of the angulation. So we know that rotator cuff anatomy, it's supraspinatus, infraspinatus, and teres minor inserts on the greater tuberosity and subscapularis on the lesser tuberosity. When we are evaluating rotator cuff muscles on the sagittal plane, it's a good thing if we start medially, and where we can identify easily the muscle bulk, the supraspinatus in between the Y, infraspinatus, and teres minor posteriorly and subscapularis anteriorly, and then subsequently evaluate the images from medial towards lateral and follow the tendons up to its insertion at its respective sites in greater tuberosity and lesser tuberosity. So these are sequential images. These coronal, the general view is that you look at just the coronals. Coronals are great, but then it's important to correlate these coronals with the sagittal planes. So we have our marker here showing the coronal on the correlating with the sagittals. As we move from anterior to posterior, the yellow arrow, it is showing the supraspinatus tendon in full view. As we move posteriorly, there'll be decussation of the fibers with the infraspinatus. More posteriorly, we start seeing the infraspinatus tendon on the coronal plane. And as we move more posteriorly, this is posterior infraspinatus tendon, which will not be seen in plane in coronal. For this posterior infraspinatus tendon, an axial would be a better view. We are here right now on the sagittal plane. For subscapularis, because of its location, obviously it will be better seen on axial plane, and subscapularis or the posterior infraspinatus tendons, they are better evaluated on axial, and again they have to be correlated on the sagittal plane. So as we move from inferior to superior, we see the subscapularis tendon as it inserts into the lesser tuberosity. Now, as I have already said, rotator cuff muscles, we need a T1 sagittal image to comment on the fatty atrophy. Biceps tendon, it's from the superior tubercle of the glenoid intra-articular portion, and then goes through the rotator cuff interval into the bicipital groove. Here on the coronals, it is the bicipital groove portion is seen. Again on axials, it's the bicipital groove portion, and that is well delineated with fluid surrounding it. And this is the intra-articular portion at the level of, almost at the level of the rotator cuff interval in the sagittal plane. So the tendons per se are dark on all sequences, and whenever there is a tear, it will be seen as bright fluid signal on the T2 or the PD fat suppressed images. So rotator cuff tendon tears, they are partial thickness and full thickness tears. Partial thickness can be further divided depending upon the location into bursal surface, interstitial, and articular surface tears. And depending upon the thickness of the muscle fibers that are involved, they can be high grade or a low grade, that is greater than 50% or less than 50%. Full thickness tears, they may be associated with retraction, and this depending upon the extent of retraction, they are classified as small, medium, large, and massive. We have a look at how a typical tear looks like. Here we see this fluid signal in the at the bursal aspect of the supraspinatus tendon, and this is a partial thickness bursal surface tear. Whatever you see on coronal needs to be replicated on the sagittal to call it a tear. This is another image, two separate cases. Here, that abnormal signal is at the articular surface. That's a partial thickness articular surface tear. The first image is a low grade, and the second one is a high grade tear. Here, there is marked thinning of the tendon, and there are only few bursal fibers that are spared. So this is a high grade tear. Now, this is a 47-year-old with pain in shoulder, difficulty in movement since 3 months. Here you see that the abnormal fluid signal is within the substance of the tendon. So this is a partial thickness interstitial tear or a delamination. These are basically horizontal fluid signals will be there in the tendon and separating or splitting the tendon into the bursal and the articular half. And whatever you see on coronal has to be correlated on your, especially on your sagittals and axials, to identify whether it is supraspinatus, a level of the conjoint tendon, or the infraspinatus. Here it is anteriorly, so it is in the supraspinatus tendon. These are images of a 59-year-old with pain in left shoulder following jerk while playing cricket 3 months ago. This, here you see the fluid signal is at the level of the footprint or insertion of the supraspinatus tendon, and this is a partial thickness avulsion of supraspinatus tendon, that is the pasta lesion, as you say. Another case, a set of MR images. Look at the upper row, which shows there is a fluid signal in the distal supraspinatus tendon at the critical zone, almost involving the entire width. That is a full thickness, near full thickness tear of the supraspinatus tendon. As we go a little posteriorly, we see this fluid cyst-like structures that are there. This is near full thickness distal supraspinatus tendon tear with intramuscular cyst, which are quite known to occur because the fluid, as it seeps through the delaminating tears and extends in the muscle bulk distally from the site of the tear. Coming to full thickness tears, depending upon the site of retracted proximal portion of the tendon, it can be stage 1 near the tendon insertion. At the level of humeral head is stage 2, and more medially at the glenoid margin is stage 3, according to this classification. So again, as you see here, this is a sono image. This is both are MR images showing a fluid signal that is involving the entire extent or entire thickness of the tendon. It is a full thickness tear. You have to see it on the sagittal to see that whether it is supraspinatus or whether that fluid signal is extending also into the infraspinatus or not. And then we measure the extent of the tear in the sagittal plane and the extent of retraction in the coronal plane. It should go all the way till here. And depending upon that, classified as small, medium, large, or massive. Once when we see rotator cuff tendon tears show the extent of retraction and where the proximal torn tendon is lying, at what level, it is important that we look at the T1 fat suppressed images to look at the extent of fatty atrophy. And there's a Gutalia's classification on which we delineate what is the grade of atrophy. Here it's almost a 50% involvement of the supraspinatus muscle atrophy is there, and there are few fatty streaks with mild atrophy in the infraspinatus muscle belly, suggesting that it is a chronic tear. Now you appreciate the signal here. Here there are bright changes in the supraspinatus tendon, but it is not fluid signal. These are just edematous changes and are known as supraspinatus tendinosis. Here, in this particular case, the abnormality is at the level of myotendinous junction. It's a myotendinous junction tear and it usually occurs following trauma. When we talk of the rotator cuff, we need to look at the subscapularis, and it's not something that needs to be missed. Once we look at rotator cuff, supraspinatus, infraspinatus tears, subscapularis also needs to be evaluated because there'll be probably a change in management if those tears are missed. So here there is just intrasubstance tear with subdeltoid bursal fluid collection. Another case where there is a complete tear with medial retraction of fibers. And one more, the third case, which shows that there is retraction and along with that the bicipital groove is empty and there is the dislocated biceps tendon associated with a complete subscapularis tear. Just to encompass a case which has all these findings, there was a complete cuff tear here with supraspinatus, infraspinatus torn and retracted, subscapularis torn and biceps dislocated and with fatty atrophy. Now, in this particular case, there are edematous changes in the supraspinatus. But note this black structure in the distal part of the supraspinatus. That is a small avulsion fracture. It is so very well and easily identified on a CT scan. If a radiograph, I don't have a radiograph, but it would definitely be seen on a radiograph as well. Probably it would have been tough, or it might be missed on an MR. But here, if you look closely, there is the cortex of the humerus missing. There is edematous changes in the humerus, and that black signal should raise the possibility of an avulsion fracture. Quite often when there are GT fractures on X-rays, the MRs are requisitions are sent to look at the status of the supraspinatus. There may be tendinosis or tear. In this particular case, there are just edematous changes in the tendon and there is no fluid signal to suggest a tear. Now have a look at this 38-year-old with shoulder pain. We don't really see any abnormality on not easily picked up any abnormality in the rotator cuff tendon that is shown here. But look at this image and we can see that there is a signal at the articular surface. So this is an MR arthrography image showing the partial thickness articular surface tear of the supraspinatus tendon. Now, yes, whenever there is a high clinical suspicion, your findings are not correlating what the MR is showing. MR arthrography is a way in which you can delineate such indiscernible tears. But in practice now, MR arthrography is just for rotator cuff tendon tears have significantly reduced. And usually on high Tesla imaging, the problems are solved. And the need for MR arthrography just for rotator cuff is very few cases are there. These are a set of old films of a patient showing or complete rotator cuff tear. And just to finish the entire spectrum, I've put up this case. This is a post-op case, and where there is a re-tear. That is, these are torn fibers and extending up to the almost up to the level of acromiohumeral joint. So this is a post-op shoulder with a re-tear of rotator cuff. This is entirely another entire topic that needs discussion.
Dr. Dushi, can you please sum up your talk?
Yeah, it's done.
Yes.
This is the last thing. So
Okay.
this is just to encompass the whole spectrum. And that is it. That's what I conclude. We need to understand the nomenclature and types to report various types of rotator cuff tear with uniformity. Thank you.
Yes, Dr. Assis wants to say something. Yeah, please.
Drushi, can you put up your presentation, please?
Yes.
I think she has comprehensively covered everything. I quite appreciate that. I just wanted to highlight something. Can you go to the Goutelier slide?
Then,
Yes.
escape first, escape. Just click escape. No, don't stop sharing. Click on that presentation and then escape. Yeah. Now start the presentation from the beginning.
About 10 slides at the end.
Yes.
Yes. So the point I was trying to make is originally when Goutelier, who's a French surgeon, described his classification, he described it on CT scan, not on MRI, because in France they still do a CT scans as such. I would like the audience to understand the difference between atrophy, which is here. This is atrophy, the fat, and fatty infiltration. So Goutelier didn't describe the atrophy. Goutelier described this, the intramuscular fat. So the classification of Goutelier is based on intramuscular fatty infiltration.
Yes.
Both features are distinct and you need to know both fatty atrophy and fatty infiltration before you
Yes.
comment on whether this is reparable or not. That is the point I wanted to make. Thank you, Drushi.
Thank you.
Thank you for a valid addition, Assis bhai. And now, is there any question so that we can move to other part? Prathamesh bhai?
Yes, sir. And Dr. Manoj wants to ask something.
Yeah.
So Dushi, this was a nice presentation, but this MRI is not available everywhere, and I am representing the common mass. So will you please say something about radiographic findings that are suggestive of massive rotator cuff tears?
So, as I had said,
Do you hear?
yes. So, as I said, there are soft tissue would not be seen on an X-ray. So, small tears obviously would not be. You cannot have any indirect evidence also. But when there are massive tears, chronic tears, there will be reduction in the acromiohumeral space, and that's an indirect evidence. Acromioclavicular joint hypertrophy is there, or there are impure osteophytes, then they can be a cause of subacromial impingement. So these are the features which are given an indirect evidence that there can be associated rotator cuff pathology if we look on the X-rays.
Okay,
And
doctor.
on the X-ray, can you, hello? On
Yes.
the this X-ray, plain X-ray, can you differentiate between large and massive rotator cuff lesions?
We don't see the soft tissues, we cannot comment on it. Even on an X-ray, we can just suggest that there might be a possibility of a rotator cuff tear, and then you need to look at another imaging modality which would show the soft tissues. If not MRIs, at least sonographies, ultrasound rotator cuff is an excellent way to dynamically evaluate the rotator cuff.
Okay, now Kalpesh B and then the Sanjay B Trivedi, right?
I can add on X-ray. If you are dealing with the chronic, long-standing, large cuff tear, then there is a proximal migration of the head of the humerus with reduced acromiohumeral distance.
Kalpesh B, keep your near the mouth.
Hello?
Yeah.
So the acromiohumeral distance is reduced. So that you can add. Now, regarding the Drushi's presentation, I would like to add that whenever you are ordering an MRI scan, please provide the adequate clinical information that you are dealing with this rotator cuff problem or instability or whatever, so that the radiologist can look into the area of interest.
That is of profound importance when we get a clinical
that is, I think, very
feedback.
important point to make here.
Yeah, Kalpesh, I think you have made a very good point, because most of the time people write out
because they have not seen the
shoulder
patient, right?
MRI.
So
Yeah.
it's always advisable.
Sanjay bhai?
Yes, regarding Dr. Chaudhary's question, you must be in habit to take a true AP, outlet view, and orthogonal view. These three X-rays will give you enough information to suspect. If you see on the true AP the greater tuberosity, which is kind of smooth, rounded off, or it is like a smooth ball, then you can safely expect there to be a chronic degenerative tear. You can also see on outlet view the osteophyte, shape of acromion, some sclerosis under surface of the acromion. So yes, you can have some inclination with clinical examination along with the plain radiology that you are dealing with a kind of big tears.
Okay, thank you, sir.
Thank you, sir.
Prathamesh bhai?
Yes, sir. Now it has been a common request from all of our orthopedic friends to learn about the management of rotator cuff tears in their own setup. So Dr. Pritesh has done a lot of work on mini open rotator cuff, and he'll teach us how to do a rotator cuff repair in a own setting in a mini open way. Dr. Pritesh, to please.
Thank you, Prathamesh. My mini open repair journey started in 2002 when I came back from Germany. I was traveling a lot in all over Gujarat and working in different routine setups. And I landed up with improper facility for arthroscopic repair. And that's how it started. First of all, I'll go for PowerPoint and then we'll see few videos. So these are basic instrumentation one must have.
No. You're not started PowerPoint. You said you're not said it.
It's not visible.
No. Only your folder is visible, not the PowerPoint.
Now.
No. You just stop sharing and go to the screen screen sharing, where we are all seen, where our photographs is seen.
Okay,
Share screen.
now I share screen.
Yeah, you share the screen and share the screen. Select the option where we are all seen.
Okay, here.
Yeah.
Now?
Now it will come completely.
Okay. Yeah. So we directly go to the
just click on the first slide and then go ahead. Okay.
Okay. So these are the instruments required for mini open rotator cuff. Here we are talking about only supra and infraspinatus. Is very difficult to repair mini open subscapularis, so I would not advise you to go for it. So these are the instruments. This is called expressive. That is, the needle is coming in this instrument. The needle goes out from here when you press, when you lock it, and it comes out with the thread. So you can get this much amount of cuff when you want to penetrate the cuff. You want to take the stitch. So this is the knot pusher. This is the sixth finger of the surgeon. Okay, so this is the rasp. You can use it for acromioplasty or for the preparation of the insertion of the rotator cuff. And this is the self-retaining retractor. So principle is to split the deltoid for minimal to access the supra and infra. Just a minute. And that is the principle. Diagnostic arthroscopy is always advisable in all cases to know the other pathologies. My technique is 1 inch incision centering lateral border of acromion depending upon the location of the tear. It can be extended. The tear area can be determined by proper MRI reading and arthroscopy finding operatively. Split the deltoid, hold with the self-retaining retractor. Don't go beyond 5 centimeter distal to lateral border of acromion. I would advise use manual retractor rather than self-retaining, because in between relaxation of muscle is better to avoid damage to the deltoid. Split the deltoid from raphe at the junction of anterior third and middle third, or middle third and posterior depending upon the site of the tear. Directly you will be on the subacromial bursa. Many times it is very thick as a tendon. So what is the differentiating point between tendon and subacromial bursa? You rotate the humerus, and if the tissue is moving along with the humerus, that means tendon. And if it is not moving, that means it is bursa. Take out the bursa as much as possible with your scissors. Don't worry about any important, because no important structures come here. Only minor oozing will be there, which looks big on arthroscopy screen. Acromioplasty I do only for type 3 acromion. You can use rotating burr, or you can use simply rasp or scoop. Identify the tear. First of all, best thing is take one traction suture. If it is a retractor one, use auto retriever, what I showed you earlier. If it is non-reducible, pass your finger above and below the tendon, release the adhesions. You can go supraglanar also for retracted tears. Debride the bed on greater tuberosity, either with a burr or rasp. Pass suture anchors, depending on either one row or double row you are doing. One anterior, one posterior, depending upon the pattern of the tear. For longitudinal split, take 1 or 2 marginal convergence stitch. And there is no need for special kind of suture passing device like clever hooks or buddy, because you have already opened the area. After taking bites, tie the sliding knots. Any of the sliding you should learn. I would advise go for operative arthroscopy by McKindy to start with. They have mentioned very good knots. Three more half-inch knots are enough for a secure repair. So what are the difference between mini open and arthroscopy I have found over a period of time? Mini open is possible in regional anesthesia. Most of the repairs are done in interscalene anesthesia. In arthroscopy, you always need general anesthesia. Mini open does not require arm positioner. And in arthroscopy, especially when you are doing beach chair, it requires good OT table with good positional like spider. Mini open does not require hypotension. Arthroscopy always requires hypotension. Systolic blood pressure has to be around 90 or 100 to have a better view around subacromial area. Mini open, I feel it's a 5 stitch in a row of as far as skin is concerned. And for arthroscopy, single stitch around 4 or 5 areas. Mini open deltoid split is required. Arthroscopy is less injurious, but here I am again debating myself. With 8 mm or 6 mm cannula, are we really preserving the deltoid or not? Mini open does not tackle subscap or other intraocular pathology. Arthroscopy tackles everything. Mini open takes average time of 30 to 35 minutes to finish. Arthroscopy takes around 1 hour. Mini open does not require like special instrumentation, a radio frequency or saline or saver blades. So it's very cost effective compared to arthroscopy technique. Here we see you make the incision, then you see for the mobility of the cuff. Then you take a traction stitch like this. So you release the adhesions. Now you can see now you put the stitches by using that or retrieving or other penetrating device. Now, very important thing is making the knots. You should learn, if you're still a routine orthopedic student, you can learn this. Because it helps you to go inside, your knot go inside, still your incision is very small. So this is called pass pointing to secure the knot. Everything is visible in front of you. So if you lock in between, doesn't matter initially. This is how it looks after repair. So this is how it looks. You can go for double row repair like this. Other patient. Now I like to show 2-3 videos.
Okay.
So this is the slide. The rotator cuff is torn.
Make
This is what we were discussing about outlet view.
नहीं करता है नहीं ये क्यों ना करना है हम फर्स्ट क्लास बनाए क्यों ना दे वो हम क्रॉप्स कम ना करता है मैंने देखा मैं
So this is the operative video. And this is 7-month post-op. We check the power, the strength of the repair. Right side is the operative side. That's it.
okay. Fantastic.
Okay.
Good one.
Thank you.
Yeah, general orthopedic surgeon can do this.
Good. That was the motive.
Yeah.
Yeah, and you can I make a comment?
Nishit bhai, I am stopping your
Navin,
video because
and you
your
don't need
bandwidth
even
is
suture
low.
anchors also. You can do a trans. Okay.
સાહેબ તમારો વિડિયો બરાબર નથી ઓડિયો બરાબર નથી
Yeah, I stopped with video. Now it will come. His bandwidth is low.
Okay. So, Pritesh, excellent presentation.
Thank you, sir.
The thing is that you were with the transosseous suture technique.
Yeah.
And the transosseous suture patcher, which are very safe. You can avoid spending for 2 or 1 or 2 anchors also.
Correct.
So that you can make even double row repair with the transosseous suture if you want to do it. And I think I like this technique because it is, as you said, it is economical. It can be done by anybody, and it doesn't involve. And after 1 year, every publication has shown the same result.
Yeah, I do both. There are cases where 2 friends I have operated, one all arthroscopy, another guy who was not insured went for mini open. Both are having same results. So probably in my experience, I would not differ that at the end of 1 year, most of the cases they do same.
Yes, I understand. But we know that arthroscopy is always better.
Yeah, of course.
Okay. Any value addition in this presentation, or we have to move ahead? Prathamesh bhai?
Yes, sir. We can now we request Dr. Sanjay Trivedi to please present his case on rotator cuff uh, repair, rotator cuff case, and he will also try to focus upon the advantages which we can provide with an arthroscopic technique in repairing of a rotator cuff tear.
Thank you very much, Gujarat Orthopedic Association, for providing this platform to the minority surgeons, orthopedic surgeons of Gujarat, who are interested in
This is not the
arthroscopy.
right comment here.
This is 48th webinar, and we are getting 2%. So one of 48th.
So let me
So
tell you,
Be
the
be optimistic.
highest viewer of this webinar was 2859, right?
so very low. We know that we attract very less
Yeah,
consumers.
yeah.
Anyway, so I'm not here to really sell you the arthroscopic repair, but since this is a general orthopedic target,
You're not shared yet your
no, I'm just talking right now. I'm
okay,
just talking.
fine.
So I'm not here to sell arthroscopic repair, or I'm not going to say that open repair is inferior and arthroscopic repair is superior. If I was talking about that, then I would involve general surgeon and ask them, why did you stop doing the appendicectomy? Open appendicectomy never had any problem, and still there are many surgeons who are doing it and giving equally good outcome. But see, the only thing which is constant is evolution of techniques, and as a reasonable surgeon one should try and upgrade themselves as and when possible to upgrade the techniques and whatever minute difference you can give to the outcome of the patient. So what I have done is I have done just a case based uh, presentation,
Very good, sir.
and the focus is actually general orthopedic surgeon. Okay, so it may be to the experienced surgeon this could be a kind of primitive, and my intentions are to discuss or to pass on an information about the rotator cuff pathology, how to identify and differentiate, but it has, this symposium has done that. My second intention is to make them understand the pathogenesis of the rotator cuff lesion and to give them a guideline to appropriately optimize treatment, and rehabilitation is probably out of this purview, and especially to give the patients realistic outcomes. So these are the terms which are loosely used by our general orthopedic surgeon colleagues. Impingement, it is tendinitis mentioned in the some of the report, tendinosis, bursitis. These are the reports which we'll try and clarify. Uh, we need to throw some light on what is the cause of cuff tear. If it is torn, then they are facing that, lot of them are so asymptomatic. Why it is so? And some people become symptomatic, they become absolutely all right, and in a year or so they come back with a symptom. Which, what kind of treatment to offer, and if at all surgery is required, when to do surgery. So let us see this lady. She is 46. She is left and dominant. She is teacher, and her job is to write on the blackboard all overhead activities situation. She didn't have any history of trauma, and she has been having pain and restricted terminal movements and during the activity of daily living, like clothing herself the and doing the household chores and also writing on the blackboard. Now she has had some amount of night pain since 5 months, and it wakes her up in the middle of the night once or twice. Her impingement is positive. She has very mild weakness. Her examination shows pain much more than the weakness of the rotator cuff muscles. And this is her X-ray and MRI. It shows a small footplate tear. So let us touch upon this impingement. Most of the time, the shoulder girdle with the interaction with the scapula and glenohumeral joint functions in a such a way that head of the humerus and tuberosity is very efficiently negotiated underneath the acromion so that there is no abutment, impingement, or there is no inflammation. In normal posterior capsule is required for that, posterior-inferior capsule especially. When there is a contracture of the posterior-inferior capsule because of some reason, degeneration or de novo spontaneous, this humeral head is transmitted little bit of anterior superior, and then during the elevation it abuts again the undersurface of acromion and there is a pain. So loss of internal rotation is the first sign of tight posterior capsule, and this is the beginning of the rotator cuff disease. And then it leads to inflammation secondary to tear, and repetitive this action leads to increase in the symptoms and continuation of the symptomology. So we all know that shoulder is a very mobile joint, and during our life shoulder is exposed and rotator cuff is exposed because of the abundant and all around movement of the shoulder to the compression, abrasion, stretching forces and all overhead activities, and this leads to a force concentration on the anterolateral edge of the rotator cuff just behind the biceps tendon, intra-articular biceps tendon, and that is known as a Codman point. And in 45 or 40 plus individual, there is already some amount of degeneration and reduced blood flow, or a critical area of the shoulder tendon is blessed with a less amount of blood flow, and that is where the lesion begins. And it was identified by Codman in 1937 with this microphotograph, and he termed this as a rim rent failure, and this is the typical location of it. And this is how it looks arthroscopically after the debridement. When that happens, patient will have an acute bout of symptom, and then there will be some discomfort in the overhead activity. General orthopedic surgeon gives them little bit of anti-inflammatory, and patient becomes all right. But he continues to have all this activity of daily living which one cannot avoid, and then this progressively the intra-tendinous, the millions and millions of fibers, and some of them keep tearing every now and then. Since this is the poorly vascular area, there will be a poor healing response. If the healing response will not be robust, and with the increased or stepping up of the activities, there will be a re-tear, there will be recurrence of symptom, and this explains that there is intermittent recurrence of the symptoms of the patient when they have this rotator cuff disease, and it doesn't have to be a particular incidence of trauma. This is a micro repetitive trauma, especially doing in overhead activities and repetitive activities, and that is how this occurs. Healing is very poor. Partial cuff tear, when they do happen, they do not heal well, and when this partial tear eventually turns into the complete tear, you know, this happens more often into the 50 plus individual. There will be actually no healing response, and it will stay as it is, and it is not going to heal. If at all it progresses, that is dependent on so many factors, and they are not very well understood or described. So this unhealed or maybe poorly scarred tissue, ultimately from supra it leads to complete footprint of supra, and then it can lead to infraspinatus. And when it involves infraspinatus, that is where patient will have weakness along with the pain. Most of the supraspinatus tear will give you most of the time pain more than the weakness. To prevent this to happening, all of my 40-45 plus individual, I advise them prophylactic capsular stretching, and that is the sure way of igniting this rotator cuff disease, even if your tendon is degenerated. And what is the primary or first line of treatment which all of you are doing is pain control. When there is adequately controlled pain by uh, pain relieving medication or steroid injection subacromial, which has been abundantly discussed by my previous colleagues, then followed by stretching exercise to get almost full range of movement, and third phase is strengthening exercise. And once you have had this attack of the so-called rotator cuff disease, it is imperative you continue some form of maintenance exercise to prevent that abnormal scapular thoracic rhythm, which is usually known as scapular dyskinesia. If you maintain your scapular humeral rhythm, then you're unlikely to have that frequent breakdown in your symptoms. So these are all have been discussed. Now coming back to that patient came to me before 4 months in the middle of the January, and I explained to her, I discussed with her that with this is your first brush with the pain, and you have been having this. Since it is a foot plate small tear, you can try conservative treatment. And recently during the lockdown, she called for a follow-up, and then I asked, how are you? She said, I'm 90% better, because she has not been attending her schools and overhead activities she has not been doing. My advice to her was to do exactly the same. But I'm sure, and I have warned her, that she is likely to have recurrence of the symptom, and eventually this tear will become symptomatic soon. But how fast this will become symptomatic, when it will become symptomatic, whether it will remain same size before she gets intervention, or it will be a bigger size, silent will be progress, it depend upon so many factors, and it cannot be reliably predicted. So message for this case was this. Can I go ahead with the another case? This is the second case. She is female, 62, housewife. She had a right shoulder pain after some jerk in the household work before 3 months. Now she has intermittent moderate amount of pain in activities of daily living. VAS scale is, when I asked, it was 7. Visual analog score is very frequently and commonly used in our practice, and it is very important, one of the functional evaluation important factor. She had no previous history of any such symptom or any injury. She has no night pain, no corbinitis. Her full can empty can was positive, but rest of the test was negative. And this was her MRI. And as you can see here, she has a sizable rotator cuff lesion. And this was her uh, um, clinical picture in the OPD. And I explained to her that you are young. She had dyed her hair, but she is young, and she will likely to need a surgery. She refused, and after then I put her on conservative trial, and after 3 months she came with this picture, and she was doubting my advice about the surgery. And this happens to us arthroscopy surgeon so many times. And when we have received some patient of such similar full thickness tear from our orthopedic surgeon colleague, and we have advised surgery, and sometimes patient goes back to them after 3-4 months and they have regained their full range of movement or nearly full range of movement, but their strength has never recovered, the fatigability is there, and the recurrence of symptoms are frequent. So they call us, and they ask, what is the way out of this? You have advised surgery, my patient feels happy about it, and patient feels, or sometimes even orthopedic surgeons, they do feel that we have wrongly advised or we are too aggressive on the surgery. But fact of the matter is that whenever there is a significant supra-infra tear, but as long as the force couple is balanced, and it is explained very well by this article by Lippert and co-workers. This is a concept of concavity compression mechanism of glenohumeral stability. We are all taught during our residency there that supra initiate the abduction and then deltoid carries forward. It's wrong. Actually, the static stabilizer and dynamic stabilizer of the shoulder joint, static is glenoid, and the labrum, dynamic is supra, infra, subscap, and teres, in the front, in the back, and on the top. The job of the rotator cuff is to centralize the head of the humerus onto the glenoid cavity so that deltoid can act. It does not allow this to happen. It allows the gliding movement of the shoulder smoothly. And when you rehabilitate your shoulder muscle, where Ashish has elegantly, described his rehabilitation program, when you do that, the force couple is established, it is well balanced. Even if there is a full thickness supra and infra tear, patient still will have full overhead elevation. That doesn't mean that these patients are cured or this patient do not need surgery. Actually, when they have force couple established and if they do overexert, the tear becomes bigger and more retracted, and when they come to us after say 4 5 6 months, the tear which was repairable and small becomes too big and expanded, and sometimes the outcome is limited in such kind of situation. So the message behind this case was that rebalancing of the force couple can restore the overhead elevation temporarily, but not permanently. And in this MRI scenario, which I showed in this case CB, future surgery is inevitable. But if you wait long enough and unnecessarily, the repairable tears sometimes become irreparable. Not only the retraction, but the muscles which are not recruited every day, when muscle tendon unit is dysfunctional, the gutelier sets in and there is a bulk of the supraspinatus is getting replaced by the fatty atrophy. And when that fatty atrophy reaches to the third and fourth stage, complete recovery is never possible and outcome is always limited. So we need to understand that. Then their a good outcome is known as a pain-free limited activity of daily living. So that was the message of the case. Look at this third case. This is 49, right shoulder. She had trivial trauma injury. She had pain restricted movement in the activity of daily living. She had night pain. The most common feature is this: whenever this patient come to us, orthopedic surgeon has already given one or two, or different orthopedic surgeons have given at least one steroid injection in subacromial space. And this was her MRI. This is probably a crescent type of tear. So usually when there is a full thickness tear, my first advice is to offer them a surgery with pros and cons, and I explain to them that you can put off surgery for a while, but whether it is worth it or not, and eventually they are supposed to be undergoing surgery. So right now the tear is small, the muscle tendon unit is as healthy as it can be at the beginning, so I would like to offer you surgery now to have a superior outcome. But decision making depends on the age in which stage they present, their activity level, their expectation. This is very important. We have to really dial down the patient's expectation if tear is too big. The recovery time is so long in a big tear. I usually tell my patient that at 6 months, you will feel reasonably fine and you will be able to do almost 60-70% of activity. But at the end of 1 year, whatever you have will be your final outcome, which is usually 10% less movement than your normal arm and 10 to 15% less strength in a best case scenario compared to your normal arm. So these factors are very important in decision making. So my current indication of operative treatment of rotator cuff is in the tendinitis or partial thickness cuff tear. I am quite reserved in my offer of the surgery to the patient. I reluctantly offer that. They have to buy surgery from me in this tendinitis or partial thickness tear rather than I offering their surgery like full thickness tear. It is failed conservative treatment, at least 4 to 6 months. They do have a disturbing night pain. They do have their main activity of daily living disturbed in such a way. And when they have failed this conservative treatment at least once or twice, and then it is the right thing to offer a surgery. But when there is a full thickness tear, I counsel them, but I offer them surgery for the reason discussed in earlier cases. So arthroscopic surgery can be done in lateral position, can be done in a chair position. You can use robotic arm holder if you have one, otherwise there is no necessary. Usually it is done with these portals in this chair position. You mark your acromion, you mark your coracoid process, and you just mark your AC joint, and then posterior portal, two finger width widow from the posterolateral portal, then anterior portal is your CA ligament. And this is the standard uh, arthroscopic surgery setup, which you can see. Most of you have probably, I assume that orthopedic surgeons have seen this one some or other time in any of the conferences, but this is how it is practically being done. The viewing portal is posterior and rest of the portals are working portal. So this is the case of this is example of the same lady which we saw in that case, and she had a crescent type of tear which I chose to treat with. She had a very good tendon. It was delaminated in the posterior part, but it was not very retracted, and I was able to reduce it to the footprint without any unreasonable undue tension. So I preferred my double row rotator cuff fixation, and this is what she was 3 months at the end of the 3 months. So for this case which I presented you, my take home message is when there is a small tear, let's say 3 centimeter tear, you can choose to do a single or double O repair depending upon your proficiency, and you can expect equally good functional outcome. All the literature in the West, in the Asia, they are saying about the same thing. However, healing rates of the double row repair are more superior when assessed radiologically, and they have less retear. This is also proved and mentioned in the literature. So, as far as I am concerned, whenever I and patient can agree upon double row repair, if tear size is 2 centimeter or more, I prefer to do double row repair, and that is the message for this case. So, look at this lady. Right shoulder, 3 months duration of pain. There is a sudden jerk and there was weakness with the pain when it started. She is 52 and she has severely painful restricted movements in all direction, quite a big retracted tear as you can see here. And this was her arthroscopic picture. Though the tear was big, you I was able to very comfortably bring that tear to the footprint margin, and that is the very essence of the choosing between single row and double row. Low tension repair is the key for any method of your rotator cuff treatment, be it even mini open or be it arthroscopic. There should not be excessive tension. It has been measured 35 Newton or less tension is optimal for this, satisfactory healing and least amount of retear rate for this rotator cuff repair. And this was done in a double row fashion, and at the end of 4 months, she was satisfactory with the movement. See, they regain their movement sooner, but the strength comes much later. So my message is bigger than 3 centimeter tear. When it is reducible to the footprint without much tension, it should be repaired with the double row technique. Look at this case. 62-year female, left shoulder, 9-month duration of pain. There was a
Sanjay
mild
sir,
jerk. Yeah.
we need to conclude, sir.
Okay. So ultimately, we can. This is the conclusion. Thank you.
Okay. Thank you very much. There are two or three questions, sir. Till somebody try to share the screen. Who is sharing screen now?
Nobody.
Nobody. Okay. So there are three questions are there. One is from Dr. Jawar Jetwa. The question is, how do you deal with over enthusiastic physiotherapists, not within your hospital but outside, while treating the shoulder pain?
So while treating the shoulder pain, I did with the tear, without tear, what kind of situation we are talking about. Let me answer everything.
Talking about the physiotherapists and over enthusiasm
Over enthusiasm
of
after
a
surgery,
physiotherapy of the
after
physiotherapist.
af-
Generalize. It is a generalized question of all the conditions.
see as a dedicated arthroscopy unit, I have made it a point to have physiotherapist, experienced physiotherapist who has been working with me since last 10-15 years in my clinic during my OPD hours, and she is supposed to attend all my cases in the OPD for the teaching of physiotherapy or post-operative physiotherapy, and then she can do that physiotherapy, take up the post-operative physiotherapy to the respective residence. She can do home visit and stuff. But in general, in urban practice, most of our physiotherapists are reasonably accustomed with the type of physiotherapy they are doing with. But our advice to the patient is to not go for passive physiotherapy as far as possible. Number one. Second, if whatever exercises increases their pain beyond say 15-20 minutes by the end of physiotherapy, that means they are doing too much. Actually, patient has to do self administered physiotherapy. That is our advice in the clinic. But if they happen to go there, then it is out of our control. But when they wish to go, we tell them that there should not be any passive physiotherapy, and that should be focused on scapulo-humeral uh, balancing. So scapular based rehab, that is what we write and send it away to the patient.
Okay.
For the adhesive capsulitis, physiotherapists are usually accustomed, but they do a lot of those, passive therapy. And best to commence exercise in a supine position, self-administer, where scapulas are stabilized, and get your movements, forward elevation, abduction, and external rotation.
Okay. Thank you.
And a few orthopedic surgeons have asked questions to, now this is a question to all panelists. Okay, do they use nutraceuticals in shoulder
No,
pain?
1 minute, 1 minute, just a minute. One or two questions are remaining. Then you start
Okay.
new topic.
Okay.
There is a question from Dr. Rajesh Gupta from Jammu to Dr. Ashish. In a stiff shoulder, in a very old patient, very difficult to differentiate clinically between the frozen shoulder and rotator cuff. Any tip?
It's a rare combination and it's a challenge always. But it's important that you send this patient first for physio, mobilize them, and reassess them once they've done the physio. Because sometimes when they're so stiff that you can't do a test of supraspinatus, infraspinatus. And at the same time, then if you're not sure, then the better to do an MRI to ensure that you're not missing a cuff tear. And to answer Jawar Jetwa, a simple statement how to prevent physios from going across the board is that there has to be a finite timeline for everything. And unfortunately, in our country, it could be 6 months, 3 months physio, 2 months physio. If a physio is going to work, you will know it in 2 weeks' time. So our physios who do their PSRB program, if they don't get a 50% improvement in 2 weeks' time or a 40% improvement in 2 weeks' time, they will send the patient back saying this is not an appropriate kind of physio. So you've not wasted anything. You've given a good trial for 2 weeks. And if it doesn't work in 2 weeks, it's not going to work in 2 months. Ideal patients should do 2 weeks supervised and the rest 2 to 3 months at home.
Okay. Okay, now the last question is, what you suggest, triamcinolone or methyl prednisolone as an injection?
Dr. Kalpesh.
Unmute yourself. Unmute yourself.
Unmute yourself.
And hold the mic near your mouth, please. Yeah.
So my preference is always
Sorry, your bandwidth is going, so I have stopped your video. Now you can speak it.
Yeah, so my preference is always triamcinolone 40 milligram.
Okay, fine. So now you can go ahead with the new topic.
So now this is the last topic. There is a question from our orthopedic colleagues that there is a lot of marketing in the by pharma companies regarding nutraceuticals and tendon supplements. Now this is the question to all the esteemed faculty, that do they use these nutraceuticals like Tendo Heal, Tendo Care, and number of such? Do they use it always? They use in selected patients, or they never use it? Starting from Dr. Kalpesh or Dr. Sanjay,
Never.
maybe.
Never.
No.
Never.
No.
Ashish sir.
Prathamesh, you show me one proper study which measures a controlled double blind between a control group and a nutraceutical that works. And I will start writing tons of nutraceuticals. all these chondroitins, diacerins, and PRPs, I don't use any of them. We are largely exercise-based program. My patients will take analgesics on an SOS basis, not on a 10-day and a 1-month basis. So let's talk science there.
So,
Okay, this was
Dr. Manoj.
Yeah, Dr. Manoj.
Yes, I consider all these as placebos.
Expensive placebos.
Expensive placebos. So they give relief to their makers, or prescribers, but not to the patients.
ये शक्ति की दवाई उसको ही शक्ति देती है, दर्दी को शक्ति नहीं देती है.
These are gimmick products.
Yeah.
Okay.
In my view, this is my view, personal view.
Absolutely correct.
Navin bhai, pati you, Puru?
Yes, Dr. Prathmesh is going ahead.
Yes, sir. So this is the message that we want to convey to our orthopedic colleagues, that usually nutraceuticals are not medications, and they have a very, very less clinical value, if any.
So there is no clinical value, there is no evidence at all.
Yes.
So just adding one comment, Prathmesh.
Yes, sir.
To Dr. Ashish's comment, for differentiating between chronic cuff tear and stiff shoulder, it is very common presentation in our setup. I usually avoid prescribing physiotherapy for 2-3 weeks because they have already gone somewhere. I always prescribe for MRI, because then unnecessarily sending them for 3 weeks, and if it turns out to be a tear with stiffness, then you are in a different position. So that was only point to be added, I think.
Okay.
I like to thank all the faculties. I like to thank Dr. Navin Thakkar to give all of us this opportunity to arrange this kind of a seminar. Dr. Ashish for his closing remarks.
Yes. No, your closing remarks. I will just like to share a screen while you speak without interrupting
Yeah, please.
Because I have not covered this, and today we are doing a very special talk in the evening, and I have done this for the first time. So go ahead, Prathamesh, you finish while screen shows up.
So I'll just like to thank Dr. Navin Thakkar sir to give us the opportunity for arranging this webinar.
It's our pleasure that we have so many faculties together here, and it's getting recorded, and so it is very useful for young orthopedic surgeons and all orthopedic surgeons. This was planned since long, but it happened a little late.
Okay.
So I'll just hand over it to Dr. Navin.
Yeah, thank you. Dr. Ashish, do you want to say, you are going to share some story? You said that you just remind me.
Right. Thank you. I had forgotten. So we were struggling to give relief to calcification patients, and we thought we were the last word in shoulder therapy. I was with Jody Beer and in South Africa for 3 weeks. And while there was a patient who had such severe pain for calcification, she had tried steroids, she had tried extracorporeal short wave, and she was in a lot of pain. She was contacting my assistants that I will wait for Dr. Babulkar to come because whatever I'm doing is causing much more pain. And so he warned me that you have to do something for her by the time you come. Meanwhile, my last day of visit, Jody Bear had a calcification patient. They had taken him theater and his assistant was operating, and they had put a scope in and they couldn't find the calcification. So we spent almost 1 hour using CM, X-rays, and we couldn't find that intratendinous calcification. And I said, this is a disaster. And he asked me, what do you do for calcification? I said, we used to do rehab. I don't believe in all these things. We used to give steroid and do rehab. And he said, no, that doesn't work. Surgery works. And so through the flight, I sat down, I picked up a lot of articles. And then I said, we came upon this where we need to plan a needling procedure. Our radiologist was unaware. So we sat down. This was a different radiologist. And I sent him messages from my flight and said, this is what we are going to plan. It took us 30 minutes to organize the first needling, and she was dramatically better. Since then, we have improvised. Our needling takes about 3 minutes. So across the world also, there's a challenge. Not everybody knows that needling works. So people are still struggling. So we hit upon this serendipitously. It's been very successful since then. That was the story I wanted to tell.
Yeah, fantastic.
And on record, Babulkar has reduced number of references to arthroscopic surgeon now.
That is pre-COVID, huh? Not post-COVID.
So better for the society, huh?
It is in always in lighter vein. Ashish knows that.
Always. Just now I am stopping the on air, and we can have a 1 or 2 minutes chat, and then we can